Apa itu mana? Nenekku indah lengan serupa itu. Dia hanya takut manja lihat muda. Acak malu amal buaan. Neneknya suko manja lihat muda. Bakalan sora soko kalado. Tapi dinai diam kau. Awal-awal ini adalah sebagai cowok tanpa pengingat jelas. Dari semua beda dengan mengadu mama. Mama siapa punya anda? Masih kecil-kecil. Balik jauh makin publik. Kau harus tegas, asli, dadah.
Big dreams start small.
We wish you a Merry Christmas. We wish you a Merry Christmas. We wish you a Merry Christmas and a Happy New Year. To you and your king, we wish.
Kepulan asap, merangkaklah menuju jalan keluar, karena posisi ini mempermudah Anda untuk bernafas. Gunakan alat pemadam api ringan yang terdapat pada sisi kanan ruangan ini untuk memadamkan api. Cara menggunakannya, pastikan jarum indikator berada pada sisi hijau
Selamat pagi Bapak Ibu yang terhormat. Selamat pagi para jajaran direksi. Selamat pagi para dokter sekalian. Dan selamat pagi untuk seluruh rekan yang kami banggakan. Good morning, honored ladies and gentlemen. Good morning to all the entire board of directors, pediatrician, doctors, nurses, midwives all around Moluccas that join us via Zoom or even via YouTube. Good morning to our excellent speakers, and good morning to all the colleagues we are proud of. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Nama Budaya, Salam Kebajikan. We offered our gratitude and praise to the Almighty God, of by His grace we are able to gather this morning. Today, I, Dr. Deliza Priyanka Mustamu, will be the master of ceremonies and I will be your host this event. Before we proceed, we will sing the Indonesian national anthem, Indonesia Raya. Attendants are requested to stand at attention. We will now listen to remarks from the Chief Director of RSUP, Dr. Johannes Limena Ambon, Dr. Gigi Saraswati, MPH. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Nama Budaya, Salam Kebajikan. First of all, I would like to express my deepest thanks and highest appreciation to our guest speakers from Saint Mariana University School of Medicine, Japan, Professor Atsushi Kawaguchi, MD, PhD, Dr. Tomoya Hanada, MD, and also Dr. Fuji for your commitment that already traveling, crossing continents to come to Ambon. Welcome in Lemena Hospital. And also to Dr. Riri Fahrina Malisi, spesialis anak, konsultan, subspesialis, emergency, and terapi intensif anak dari Ikatan Dokter Anak Indonesia. Dr. Farah atau yang mewakili dari Fakultas Kedokteran Universitas Patimura, kemudian directors from all Moluccas that present online or present in this room, board of directors from Rumah Sakit Lemena, Lemena Hospital, distinguished guests, ladies and gentlemen. Thank you that now in this lovely morning we could convey to these meetings, and also we hope that this symposium could perform good, because now from data regarding the respiratory infection disease under 5-year mortality rate in Indonesia, from data globally, that if we compare Indonesia to Japan, that the data recorded 10 times higher. So respiratory infection disease account approximately 60 to 70% of the deaths, make it the deaths of the under 5 mortality. For example, pneumonia, mortality in 2023 from UNICEF global data in Indonesia, 21.3 deaths per 1,000 live births, compared to Japan, only 2.4 deaths per 1,000 live births. So through this event, I hope that we can achieve the following the following target: obtain the latest scientific updates related to the management of pediatric patients in critical conditions. And also we do hope through this event we could strengthen the capacity of health workers, especially for workers in Moluccas province, both doctors and nurses, in providing faster and more accurate and also evidence-based services. And of course, build international networks. Through this event, we could hope that it will strengthen our build international networks, so that in the future we can continue learning, collaborating, improving the quality of pediatric critical care services in Moluccas and also in eastern of Indonesia. And I hope that from this event we could have a very fruitful discussion with a very good lectures, resource persons that already come to Ambon. Finally, I warmly welcome and appreciate the organization of this international guest lecture. I hope this activity brings great benefits, opens our new insights, and becomes a concrete step forward, improving the quality of pediatric critical care services in Moluccas province, especially in our hospital. And lastly, with the words Bismillahirrahmanirrahim, I hereby officially declare the International Guest Lecture Comprehensive Pediatric Care open. Thank you. Wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Gigi Saraswati, MPH. Now, before we start, let me introduce our amazing guest and also speakers who's gonna talk us through this seminar about comprehensive pediatric critical care, progress and early management of critically ill patients. First, welcome to RSUP Lemena, Professor Atsushi Kawaguchi, MD, PhD. Dr. Riri Fakhrina Malisi, spesialis anak, konsultan, subspesialis emergensi dan terapi intensif anak. Dr. Tomoya Hanada, and Dr. Fuji. We will now begin our seminar with our pediatrician, Dr. Suweda, Specialist Anak, as the moderator. The floor is yours.
Thank you. Ladies and gentlemen, may I have your attention? Our international pediatric lecture is about to begin. Please have a nice seat. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Respectable, the head of hospital, RSUP Dr. Johannes Lemina Ambon, Dr. Gigi Saraswati MPH, and the direction, and also all participants from all of the hospital in the Molucas province. The Honorable all lecturer and staff of the hospital also, welcome to our seminar today. And ladies and gentlemen, I'm Zubade Hanusa, Specialist Anak, the moderator of the today International Pediatric Lecture. I'm very pleased to see you and welcome all of you to the lecture. So today we will have a very nice and very honorable presentation from Japan. Yeah, maybe for Molucas this is the first time. Ya, saya pakai bahasa Indonesia ya, karena jangan sampai ada juga yang tidak bisa. Ya, jadi ini adalah hal yang sangat berbahagia sekali buat teman-teman sekalian ya, bahwa kami kedatangan para pembicara dari Jepang ya. Dan ini adalah pertama kalinya di RSUP Dr. Johannes Lemina. So I say thank you for Japanese team to come here to the hospital. And for the first presentation, let me invite Dr. Tomoya to make the presentation. So please. Yeah, the place is yours.
Sorry.
I want to tell about them about your TV first. Or, okay. Jadi kalau thank you. First of all, I want to tell about the curriculum vitae of Tomoya Hanada MD. Yeah. For the personal information, Mr. Tomoya Hanada was placed birth in the Okayama, Japan. Yeah. The home address is Osukoro Okunomoto, Tokyo, Japan. Siapa tahu ada yang pernah ke Tokyo, Jepang? Ya, beliau tinggal di Tokyo, ya, di Setagayaku. Ya, so dan masih single ya. Ini kemarin banyak sekali yang minta foto sama beliau, jadi beliau jadi selebriti di Peru, ya. Siapa tahu kalau macam bisa ada yang minta foto juga boleh, ya. Terus then, for the current professional position, Mr. Tomoya was assistant professor for Division of Pediatric Critical Care, Department of Pediatric, Saint Mariana University Hospital, and for the education, Mr. Tomoya, for 2007 until 2013, she was graduated from Okayama University School of Medicine. For 2013 until 2015, he was junior resident in internal medicine, National Hospital Organization Okayama Medical Center. And for 2015 until 2018, he was a senior resident in pediatric, Hagoyo Prefectural Amagasaki General Medical Center in Hyogo, Japan. And now he was assistant professor, Division of Pediatric Critical Care, Department of Pediatric, Saint Mariana University Hospital, Tokyo, Japan. So that is a curriculum vitae of Dr. Tomoya Hanada, and the place is yours.
Thank you for the introduction. Hello everyone, nice to meet you. And nama saya Tomoya Hanada. And it's I'm a pediatric intensivist at St. Mariana University Hospital in Japan. And it's a great pleasure and honor to meet you all and to share our experience and to speak here. And today I'd like to present about respiratory management for pediatric patients. And this is our PACU, PQ, and our colleagues. And let's get down to today's main topics. Today's objectives and topics are mainly two. And one is respiratory assessment, and the other is about timely interventions. And first, look at this picture of baby. Can you think of any characteristics of children's respiratory system? And this slide shows the characteristics of pediatric respiratory system. Children have many characteristics, and on the left side, we show characteristics, and on the right side, the result. Large head, short neck, relatively large tongue, small nasal cavity, obligatory nose breathing, short narrow pharynx, larynx, short narrow trachea, bronchi, short thorax, relatively large liver, and these characteristics causes airways easily narrowed, obstructed. Intubation tube is easily displaced. High nasal resistance, nasal obstruction, prone to chest retraction, respiratory fatigue, prone to ventilation failure. And to summarize, these characteristics causes a sudden onset of respiratory distress and rapid progression to respiratory failure. And so therefore we need proper assessment and intervention specific to children. And this slide shows severity and types respiratory disorders. We classify the 2 levels of severity and 4 types. And respiratory distress, and if it progresses, respiratory failure. And types are upper airway obstruction, lower airway obstruction, lung parenchymal disease, and this means lung tissue disease. And disorders control breathing. And this slide is the main concept of today, importance of recognizing our signs. And sorry. Just a moment, sorry. It's small. That's okay. And sorry, this is the most important point in my presentation. And in order to prevent progression to respiratory failure and or CPA, we need to recognize early signs and make timely interventions. In terms of timing, there may be a couple of hours between respiratory distress and respiratory failure, but between respiratory failure and CPA, the remaining times can be extremely short, sometimes only a couple of minutes. So how can we recognize the early signs? And so take a look at this baby. This baby has these vital signs. What is seeing? Is that all right? And since SpO2 is still 99%, this is the patient might be doing fine so far. It's not all right. And SpO2 is the last one to deteriorate. And this graph shows a pattern of unexpected hospital deaths. And this parameter shows red line is SpO2, green line is PaCO2. And black is respiratory rate, blue is minutes of ventilation, As you can see, SpO2 is the last parameter that was so other parameters are more important to assess, such as facial expressions, skin color, and the child is energetic or not, and respiratory effort. In other words, the general appearance, and of course, respiratory rate, heart rate, and the trend of the vital signs are also essential. And this is the clinical characteristics of respiratory distress and summarized in this table. Sorry if I explain each item one by one, it would take too long. So let me focus on just top one. In upper way obstruction, and the representative causes are ingestion of a foreign body, anaphylaxis, croup syndrome, and masculine airway, glossoptosis, etc. And representative symptoms are inspiratory restrictions, prolonged respiration, stridor, hoarseness, changing voice, and barking cough. And this slide shows the effects of airway obstruction, and particularly the difference between upper and lower airway obstruction. On the left side, the upper airway expands during expiration because of the positive intratracheal pressure, but it tends to narrow during inspiration because of the negative intratracheal pressure. And this narrowing produces abdominal inspiratory sounds known as stridor. And meanwhile, on the right side, the lower airway expands during inspiration because of the negative intrathoracic pressure, but it tends to narrow during expiration due to the positive intrathoracic pressure. And this narrowing produces abdominal sounds known as wheeze. And this is a table showing normal respiratory pattern by age group. And infants primarily use abdominal breathing, toddler abdominal thoracic breathing, school-age children thoracic breathing. And what I want you to remember is written below. Inappropriate breathing pattern for the child's age is abnormal. For example, an infant using thoracic breathing and this is a bit of a side note, but I think all of you are familiar with chest retractions. But do you have an idea of which type of retraction indicates the most severe distress? Sorry, already indicated. Generally, retraction in the upper areas, such as the supraclavicular and supraesternal regions, are considered more severe than those in the lower side. Yeah, and we show the video and does it move? Sorry, just a moment. Okay. 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 Now we show some real cases of retraction. And this boy is the asthma patient at UR. And you can see the substernal and subcostal retraction and mild moderate retraction. And next. And this patient is Krupp syndrome or something. And you can see not only substernal, but also the supraclavicular and suprasternal retractions. This is severe case. And next, you can see the paradoxical chest breathing. It's a more very severe retractions. And next. This is just before intubation. Ideally, we should take action or intervention before the patient reaches the stage. Okay. From here, and I show some easily overlooked respiratory distress pattern. And this is the children who are used to asthma attacks. And so these children may not report obvious signs of distress, even when retraction are present. And this is nasal wailing.
She was a premature baby, right? Yeah, so that's nasal flaring. So we'll
This is also a sign of our
as an
science.
example for teaching other doctors and nurses.
So it sounds I can't hear, but this shows grunting. Sounds like this. And this head bobbing. This sign is seen when the child is using their respiratory accessory muscle forcefully. And this is because relatively their neck is soft, flexible. Okay, just a moment. Actually, oh, okay. Now, okay, sorry. Yeah, I can use the icon. Yeah. So sorry to write. From here, I will explain what kinds of interventions should be performed. And this slide shows what we should do first as a nurse. And first, if there's any obstruction, such as nasal discharges or mucus, and for the body something, we should remove it. Second, when the patient is lying flat, the airway is more prone to obstruction, so place a shoulder load to help open the airway. And the third, if the patient is crying or agitated, we should comfort them to decrease lack of breathing. And even so, if you judge that the patient is experiencing significant respiratory distress, you should prepare for monitoring and IV access. And we should start non-invasive respiratory support in a timely manner. There are 3 types of non-invasive respiratory support, and that should be provided before the patient reaches the respiratory failure. And the left is O2 therapy, and the middle is hypernasal cannula. The light is NPPV, non-invasive positive pressure ventilation. And so please take a look at this patient again. SpO2 is still 99%. I'm going to give oxygen or not. Maybe yes. You have to prepare or give oxygen if the patient has signs of the respiratory distress. And the baby is trying to compensate and maintain higher SpO2 by breathing rapidly and using accessory muscles. So we must not let the baby work hard for a long time and start to support the baby before they tires out. And just one question, is it better to give as much O2 as possible? And it's not. Giving too much O2 can be harmful, and because of O2 toxicity. It is said that providing FiO2 greater than 60% has possibility for developing O2 toxicity. And so ideally, efforts should be kept below 6% and preferably below 40% whenever possible. And although the target SpO2 is listed as 94 to 98%, but in some situations, a lower level around 90% may also be acceptable. Wearing nasal high flow or BiPAP and sometimes makes quite tight and gives a lot of pressure on children's skin. So we should take cautions on skin protections. There's some examples of skin protections. The left shows commercial nasal bronch, and that has thick cushion dressing. The middle shows the same kind, and the right shows handmade dressing, which has a thick dressing and upright, so that the bronch doesn't touch the skin directly. And this is silicone gel, and silicone gel dressing is upright where the mask touches the skin. The strap causes skin damage in many cases, so we applied silk dressing or cushion around the neck. And when peeling the dressing, and that can cause skin damage easily. So we use some kind of skin wipe or wet towel for wetting the dressing. Okay, this is my this is for my whole presentation. Thank you for kind attention.
Tepuk tangan. Thank you, Dr. Tomoya, for your excellent presentation. Please take your seat on the podium. And for your information, a question and answer session will be held after all speaker have presented. Ya, jadi, I'm sorry, I'm taking bahasa. I'm speak with bahasa. Ya, jadi tadi itu Dr. Tomoya ya buat teman-teman perawat. Jadi Dr. Tomoya tadi menjelaskan mengenai bagaimana cara mengenal bayi-bayi yang mengalami kesulitan bernafas, ya, yang mengalami gangguan nafas. Jadi tadi juga dijelaskan bagaimana sih kita mengetahui tanda-tanda bayi-bayi yang lagi mengalami kelainan bernafas, ya. Kita mengenal apakah bayi ini gangguannya itu di mana, ya, apakah di paru-paru, bagian atas kah, bawah kah, ya. Dan bagaimana cara penanganannya, ya. Jadi dari kesimpulan presentasi yang dibawakan oleh Dr. Tomoya, ya, menjelaskan bahwa kalau kita bisa mengenali sejak dini kegawat nafas pada bayi, kalau kita bisa tata laksana sejak awal, maka anak itu bisa memiliki kondisi yang akan lebih baik, ya, dan tingkat kematiannya juga akan menurun. Seperti itu. Kira-kira kalau ada pertanyaan, teman-teman sejauh sekalian bisa nanti bertanya setelah akhir seksi, ya. Ya. Okay, now I will pronounce the second presentation from Dr. Riri Fahriani. Please be seated on the podium, Doctor. Okay, I want to introduce Dr. Riri, ya. So, for your attention, ya, Dr. Riri Fahriana Malaysia, SPA Konsultan Subspesialis Etia, is from Faculty of Medicine, University of North Sumatra, Indonesia. She is a chairman of Emergency and Pediatric Intensive Care Working Group of Indonesian Pediatric Society for 2017 until 2024. And she was chairman of a health technology assessment task force of Indonesia Pediatric Society from 2024 until now. Yeah, please join me in and welcome Dr. Riri Fahriana, Malaysia SPA Konsultan Subspesialis Etia. And this podium is yours. Thank you.
Thank you, Dr. Zubaida, for the very nice and kind introductions. And thank you for this opportunity for us to share our experience and we can discuss together. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera, shalom, om swastiastu. Please allow me to present in Bahasa. Our honorary guest speaker, Professor Atsuse Kawaguchi, Dr. Tomoya Hanada, and Dr. Fujiko. Terima kasih Ibu Direktur dan jajarannya tentu dan teman-teman sejawat dokter anak di seluruh Kepulauan Maluku. Ya. Perkenankan saya mewakili teman-teman dari Ikatan Dokter Anak Indonesia untuk berbagi mengenai tata laksana kegawatan terutama pernafasan dan tadi kita sudah dihantarkan dengan sangat baik oleh Dokter Tomoya walaupun mungkin presentasinya in English tapi kita bisa lihat gambarnya dan presentasinya itu sangat jelas sebenarnya mengenai bagaimana kita mendeteksi suatu kondisi gawat napas ya dan akhirnya menjadi gagal nafas yang sangat berat yang perlu tindakan tata laksana lanjutan. Saya memberikan suatu perantara antara presentasi Dr. Tomoya dan Prof. Atsushi yang nanti akan lebih detail menjelaskan tata laksana gawat napas pada bayi dan anak. Nah, kita tahu saat ini mungkin teman-teman sudah biasa melihat mesin-mesin yang perlu membantu pernapasan bayi dan anak terutama di masa neonatal. Mungkin belum banyak yang mengetahui tentang bagaimana kita memberikan tata laksana pernafasan dan pada kondisi terutama gagal nafas juga yang dapat dilakukan tanpa intubasi atau pemberiannya non-invasive ventilation. Tetapi saya akan saat ini mengemukakan mengenai bagaimana kita mengenali secara dini, ya tadi sudah disampaikan oleh Dr. Tomoya, tapi kita mengenali secara dini kemudian melakukan tata laksana inisial atau stabilisasi untuk pasien-pasien anak yang mengalami gawat nafas dan kegawat darurat yang lain. Ini adalah data ya. Ini data kita ya bahwasanya kita harus mengakui saat ini Indonesia adalah negara keempat terbanyak penduduk di dunia. We are the fourth largest population in the world. Jadi jumlah penduduk kita saat ini adalah 276 juta jiwa ya. Nah, dengan di mana di antara ini adalah anak-anak itu 88.000 enggak ya, 88 juta ya, di mana juga angka kematian itu 23 ya per 1.000 kelahiran hidup. Itu sangat tinggi. Karena apa? Karena rata-rata dunia memang mensyaratkan adalah penurunan dari 30 menjadi paling tidak sekitar setengahnya 15. Rata-rata kematian Jepang itu di bawahnya lagi yaitu 7 di antara 1.000 kelahiran hidup. Jadi kita masih sangat tinggi angka kematian pada anak balita. Ini adalah musuh kita bersama yang selalu dititipkan oleh Bapak Ketua PPIDAI kami. Nah, kemudian apa penyebab kematian pada balita kita yang banyak itu? Yaitu adalah ada yang coret ya. Ya, ini di mana penyebab utama kita lihat di sini pneumonia. Ya, pneumonia, kemudian di bawahnya adalah diare, ya atau mindset ya dan gastrointestinal dan yang nomor 3 itu sepsis, kemudian malaria. Malaria adalah penyebab nomor 4 kematian bayi dan anak, ya dan kemudian baru penyakit ini penyakit infeksi semua, ada infeksi measles, campak dan HIV saat ini. Jadi kita bisa lihat angka kematian bayi dan anak ini terutama balita di bawah 5 tahun yang paling tinggi adalah pneumonia. Dan kita lihat lagi dari data review ya yang dilakukan oleh Ikatan Dokter Anak Indonesia bersama BPS bahwasanya tidak tergantung pada jenis rumah sakit, bahkan rumah sakit tipe A pun kalau kasusnya sudah datang sangat berat, angka kematiannya sama. Artinya apa? Artinya kalau kasus sudah sangat berat, bahkan di rumah sakit tertinggi rujukan tipe A pun nanti, yang mudah-mudahan rumah sakit Lemena dapat menjadi tipe A, itu tetap juga tinggi. Tetapi angka kematian itu dapat diturunkan jika rumah sakitnya mempunyai ruangan PICU atau ruangan HCU dan NICU. Itulah kira-kira yang dapat kita ambil dari tabel hasil audit kematian bayi dan balita di bawah 5 tahun ya yang dilakukan oleh Ikatan Dokter Anak Indonesia bersama BPS. Dan ini adalah availability atau ketersediaan ruang PICU di Indonesia dan distribusi dari dokter-dokter anak. Ya. Kami tahu ya sangat beruntung bahwasannya Dr. Zubaidah adalah Ketua Ikatan Dokter Anak Indonesia cabang Maluku saat ini dan beliau mengomandoi 29 dokter anak sekepulauan Maluku provinsi. Tapi kita tahu dan saya lingkar itu adalah benar ya geografi kepulauan Maluku. Wah, tidak ada atau belum ada pediatric intensivist di situ dan kita juga lihat saat ini ruang yang dideklarasi sebagai ruang PICU saat ini baru hanya ada di rumah sakit ini, di Rumah Sakit Leimena untuk seluruh provinsi Maluku. Ini adalah data yang ada. Nah, sehingga kan setelah lihat tadi dengan adanya ruang PICU kita harapkan dapat menurunkan angka kematian. Tentu itu sambungannya. Sekarang topik yang akan saya sampaikan ya, kita untuk mengenali atau melakukan tata laksana, kita kenali dulu. Pepatah Indonesia, tak kenal maka tak sayang, bukan? Ini kalau tak kenal maka tak dapat melakukan upaya preventif dan upaya tata laksana. Sehingga kita harus memahami sedari dini, mengenali sedari dini, ini bayi dan anak mengalami gawat napas atau gagal napas atau kegawat daruratan yang lain. Dan ada kita dari Ikatan Dokter Anak Indonesia sudah mempromosikan suatu pengenalan dengan segitiga. Apakah ibu-ibu, dokter-dokter, bapak-bapak sekalian sudah pernah mendengar segitiga kegawat daruratan? SAGA, segitiga asesmen gawat anak atau pediatric assessment triangle. Mungkin kalau belum sama-sama kita akan dengar nanti. Kemudian bagaimana kita melakukan tata laksananya. Jadi intinya adalah mengenali sedari dini tentu lebih baik. Ini berlaku pada untuk seluruh petugas tenaga kesehatan sehingga kita dapat melakukan segera. Namanya apa? Survei primer. Ya, jadi kalau dalam pengenalan kegawat daruratan kita cukup mengenali dengan secara cepat, nggak sempat nanya-nanya. Jadi kita nggak sempat analisis, Bapak Ibu. Jadi kita lakukan pendekatan dengan segitiga tadi dan ini sangat berlaku pada rumah sakit besar yang mempunyai sistem EMS. EMS itu namanya adalah emergency triase ya atau emergency medical system, di mana apabila ada kegawat daruratan akan ada bunyi code blue. Pernah dengar di rumah sakit ini, saya yakin pasti ada. Code blue itu adalah tanda kegawat daruratan sehingga kita dapat melihat rangkaiannya apabila kita deteksi ini suatu kegawatan dengan segitiga tadi, pendekatannya akan saya jelaskan berikutnya. Kemudian kita akan lakukan pemeriksaan dengan primary survey atau survei primer A, B, C, D, E dan kemudian dilakukan tata laksana lanjutan. Nah, ini adalah segitiga sama sisi yang menggambarkan 3 organ penting penyangga kehidupan. Organ penting penyangga kehidupan secara medis ini apa saja, Bapak Ibu dan teman-teman? Yaitu 3 sistem organ. Pertama, sistem saraf pusat, itu adalah appearance, mewakili penampakan. Bukan penampakan ya, penampilan. Kalau penampakan lain lagi nanti ilmunya ya, Dokter Eda. Nah, kemudian pernapasan yang work of breathing itu sistem termasuk jalan nafas. Yang di bawah adalah segitiga yang bawah itu adalah sistem daripada kardiovaskular atau jantung dan pembuluh darah. Jadi ketiga sistem ini akan kita deteksi secara cepat, tidak perlu pakai pemeriksaan macam-macam dan tidak perlu pakai laboratorium. Hanya butuh waktu 2-3 menit untuk menilai seorang bayi dan anak ini gawat atau tidak. Dan pemeriksaannya hanyalah kualitatif, impresi saja dalam waktu 2-3 menit. Apa yang kita nilai tadi itu? Yaitu sistem saraf pusat, kemudian sistem pernafasan termasuk jalan nafas, dan sistem kardiovaskular. Bagaimana caranya? Nanti kita lihat. Jadi pendekatan inisial ini ya secara dini apabila kita dapat terapkan dengan baik itu sangat membantu menyingkat waktu dan kita tidak sempat lagi akan melakukan suatu upaya tanya jawab atau history talking atau anamnesis sehingga kita bisa lakukan pemeriksaan primer survei atau survei primer dengan ABCDE ya. Jadi yang pertama diperiksa adalah behavior tadi, appearance atau apa? Tingkah laku, apakah seorang bayi dan anak yang menunjukkan fungsi susunan saraf pusatnya ini ada perubahan tingkah laku. Tingkah laku itu mulai dari kesadaran, arah pandangan, apakah ada kejang atau ada yang lain. Ini akan kita lihat. Saya akan tampilkan dan tunjukkan dengan video. Bapak Ibu bisa amati. Coba lihat, amati pasien ini, anak ini ya. Kami sudah minta izin pada keluarga untuk ditayangkan dan mohon tidak direkam karena ini adalah hak pasien. Kita bisa lihat tonus otot. Apakah anaknya mampu bergerak? Motoriknya bagaimana? Kelepek bukan bahasa Jawanya? floppy. Kemudian apa? Apakah dia mampu berinteraksi? Matanya bisa natap kita? Apakah anaknya tampak nyaman? Anaknya jelas tidak nyaman, tidak baik-baik saja. Arah pandangannya satu arah, kita kejap-kejap begini juga matanya tidak berkedip. Dan bahkan anaknya ini tidak mampu untuk bahkan merintih menangis. Secara cepat dengan 5 item ini, dia tidak mampu bergerak dengan baik, tidak bisa berinteraksi dengan sekelilingnya, anaknya jelas tidak nyaman, arah pandangannya cuma satu arah, kita nggak bisa ganggu, dan dia bahkan tidak mampu menangis. Secara cepat semua Bapak Ibu, dokter-dokter, teman-teman setuju bahwasanya ini tidak baik-baik saja. Ini secara cepat menunjukkan susunan saraf pusat sistemnya terganggu. Kita hanya nilai abnormal, normal. Gampang sekali untuk menilai seseorang bayi dan anak itu gawat apa tidak. Ini satu, impresinya semua setuju, ini adalah gawat, ini tidak normal. Oke, sekarang kita lihat berikutnya. Lebih jelas lagi yang tadi. Ya, biar masing-masing akan mengecam di dalam ingatannya bahwasanya kondisi seperti ini jelas adalah gangguan dari sistem saraf pusat. Oke. Kita lanjutkan ke video berikutnya. Bandingkan. Maaf kalau suaranya nggak terlalu besar ya. Atau itu bisa dibesarkan?
Enggak, bentar lagi selesai kok.
Ya. Nah, kita lihat berbeda dengan anak sebelumnya. Dia masih bisa bergerak, cukup melawan, ya kan? Tonus ototnya masih baik, matanya masih cari-cari emaknya, ya kan? Masih bisa bersuara dengan baik, artinya menangis, ya. Kemudian dia masih tampak cukup baik, artinya dia cukup nyaman, cukup dipegang saja dia masih bisa bergerak. Nah, kita sama-sama melihat perbedaan video pertama dan kedua. Apakah anak ini mengalami abnormalitas dari sistem saraf pusat saat ini? Tidak. Ya, oke. Ya, betul. Karena yang dia alami saat ini adalah sistem yang lain yang terganggu. Sesak napas, tapi dia masih cukup baik di sistem saraf pusatnya. Oke. Ya, karena tiga segitiga itu akan kita nilai. Yang berikutnya.
Ganteng banget. Sayang.
Anaknya masih bisa senyum, senyum manis pada ibunya, senyum manis pada penolongnya, bukan? Dan dia tampak nyaman, ya enggak? Dia masih cukup pegang-pegang perutnya, ya. Jadi ini menunjukkan video di mana sistem saraf pusatnya baik-baik saja atau normal, ya. Oke, kami kira ini cukup jelas untuk menunjukkan perbedaannya. Nah, sekarang kita masuk ke penilaian sisi satu lagi. Kan segitiga bukan? Yang satu sisi adalah penilaian sistem saraf pusat. Satu lagi penilaian pernapasan. Apa yang kita nilai? Ya, nilai bagaimana laju napasnya, bagaimana suara napas terdengar apa enggak, kemudian dia menggap-menggap apa tidak. Ada tadi yang ditunjukkan oleh Dr. Tomoya. Secara cepat, ini tadi sudah saya tunjukkan yang menunjukkan suatu gangguan. Oke. Ya. Nah, ini video yang sama, tapi ini menunjukkan bahwasanya pasiennya sesak napas. Lihat, ya. Jadi sistem yang tadi nilai sistem saraf pusat, sekarang kita lihat adalah tarikan dinding dadanya, sama seperti tadi yang sudah ditampilkan Dr. Tomoya. Ya, bahwasanya ada apa? Masalah pernapasan, ada cuping hidung, ada retraksi atau tarikan otot-otot dinding dada, ya, dan otot-otot pernapasan lainnya. Ini juga kita bisa lihat ada tarikan di perut, ya. Bayi dan anak itu tadi Dr. Tomoy sudah sampaikan kalau bayi di bawah 1 tahun dia bernapasnya abdominotorakal. yang diayunkannya adalah otot perut. Tetapi kalau anak besar sama seperti kita yang diayun adalah dinding dada. Kalau bayi, balita di antara itu adalah dua-dua. Jadi kalau bernafas dia perutnya juga kembang kempis, dadanya juga kembang kempis. Oke, yang terakhir adalah apa? Kita menilai sistem dari pembuluh darah dan jantung atau kardiovaskular. Oleh karena kita hanya melihat, tidak meriksa, tidak pakai stetoskop, kita lihat adalah warna kulit. Itu paling penting karena menunjukkan bagaimana aliran darah dari jantung sampai ke kulit, ke perifer namanya. Sehingga yang kita lihat apakah anaknya tampak biru, tampak pucat, atau bahkan ada yang lain. Cukup lihat saja bibir, mukosa, selaput lendir, karena itu sangat menentukan atau memperlihatkan anaknya sianosis apa tidak. Kalau terlihat warnanya ungu seperti gambar di sini, cukup juga kita berikan oksigen. Jika sianosis atau gambaran birunya menghilang, berarti permasalahan terletak di paru. Tapi apabila sudah kita berikan oksigen, birunya tetap atau menetap, berarti kemungkinan besar permasalahan terletak di aliran jantung. Ya, jadi ini juga yang sering disampaikan teman-teman dokter jantung anak untuk deteksi penyakit jantung kritis. Nah, kemudian di tengah tampak pucat dan atau kutis marmorata menunjukkan aliran darah ke perifer itu terganggu. Ya, nah sekarang klasifikasinya adalah segitiga tadi. Ingat seperti lampu setopan. Ibu-ibu masih ingat atau sudah paham kalau yang bawa kendaraan ya? Kalau hijau artinya berarti jalan. Seluruh organ yang kita nilai tadi ya fungsinya baik, jalan dia. Tapi kalau merah berarti fungsinya berhenti ya. Sama seperti kendaraan bukan? Berarti kita harus berhenti di lampu merah. Tapi kalau kuning, kuning bagaimana ibu-ibu? Kuning hati-hati mau berhenti. Bukan, kalau anak saya bilang kalau kuning itu lampu stetopan mami itu artinya tancap gas. Loh kenapa tancap gas? Karena papi begitu, setiap ada mobil warna kuning papi langsung tancap gas karena dia bilang nanti mau berhenti kita mau cepat begitu. Tapi seperti saat ini saya pikir ya, saya berpikir mungkin nih Bapak Ibu juga setuju. Dalam kondisi seperti ini saya setuju dengan prinsip suami saya itu. Kenapa? Karena pada saat hampir berhenti fungsi organ, kita harus tancap gas. Jangan berhenti pula, begitu loh. Nah, itulah ada konteks bahwasanya apabila kuning, tapi bukan lampu lalu lintas ya. Apabila warnanya kuning, kita harus tancap gas. Supaya apa? Supaya jangan berhenti organnya. Nah, bagaimana penilaian supaya kuning ini jangan menjadi merah? Penilaiannya adalah apabila salah satu abnormal dari segitiga itu berarti dia kuning. Atau hanya satu yang normal, berarti dia kuning. Hati-hati, mau berhenti mau merah. Kalau tiga-tiganya abnormal, sudah berarti dia gagal jantung, paru atau kardiovaskularnya sudah terganggu dengan pulmonerinya. Ya, jadi kalau sudah terjadi merah, berarti kita harus lakukan apa? Basic life support atau bantuan hidup dasar. Tapi kalau kuning berarti kita lakukan tata laksana sesuai yang kita temukan. Kalau dia hijau berarti baik. Ini dia. Jadi kalau dia stabil, barulah kita mulai lakukan. Ingat tadi ya dok, ibu-ibu, bapak-bapak, bahwasanya pemeriksaan dengan segitiga ini hanya untuk menilai impresi saja. Tidak kita memeriksa apa? Pakai stetoskop, tidak kita menghitung. Jadi hanya menilai. Setelah itu baru kita lanjutkan dengan primary survey menilai A, B, C, D, E. A, B, C, D, E itu apa? Airway, itu adalah jalan nafas. B itu breathing. C itu sirkulasi. D disability atau fungsi neurologik, dan E adalah exposure atau tampilan luarnya ya. Nah, sebenarnya kalau kita lihat di buku-buku luar dan berbahasa Inggris itu kayaknya ribet, tetapi pada sejatinya adalah A itu adalah bagaimana kita mempertahankan jalan nafas tetap terbuka, B itu kita menilai apakah pernapasannya berlangsung cukup baik, normal sesuai usianya, C itu apakah fungsi daripada jantung pembuluh darah atau fungsi sirkulasinya baik. D itu fungsi susunan sarafnya tadi, apakah anaknya kejang atau tidak. Dan E eksposur, apakah ada katakanlah ruam atau kalau demam berdarah ada bintik-bintik perdarahan. Jadi ini adalah rangkaian dari tadi pendekatan segitiga, kemudian segi 5, kemudian menjadi segi 6. Gampang bukan? Segitiga tadi pendekatannya cukup lihat dalam 1-2 menit, kemudian kita lakukan primary survey dengan ABCDE, nilainya sangat sederhana bukan? Hanya menilai laju napas, kemudian menilai tekanan darah, menilai nadi, ya enggak? ABCDE, lihat kulitnya, ada enggak perdarahan apa tidak, ada bintiknya. Nah, baru dilanjutkan pemeriksaan seperti biasa, kita memeriksa anak mulai dari ujung rambut sampai ujung kaki. Yang tidak akan saya terangkan di sini. Nah, yang penting adalah tanda bahayanya. Apa itu? Apakah anaknya berhenti bernapas atau tersengal-sengal atau megap-megap bahasa Jawanya, ya? Apakah ada tanda-tanda distress napas yang lain atau bahkan dia nggak bernapas sama sekali, atau dia tidak sadar, atau dia shock, yaitu tekanan darahnya turun, atau tiba-tiba dia dari baik tidak bernapas dan tidak berdenyut jantungnya. Kita sebut itu arrest, henti napas, henti jantung. Apa yang kita lakukan? A, B, C, D, E lagi, yaitu tadi tata laksana jaga jalan nafas, yaitu airway, kemudian berikan oksigenasi. Nanti akan lebih detail diterangkan oleh Prof. Atsusi bagaimana kita membantu seorang bayi dan anak yang mengalami gagal napas, gawat nafas dengan terapi oksigen. Saya hanya memberikan pengantarnya. Dan kemudian kalau memang tidak mampu sama sekali, seperti kemarin Ibu Direktur, kami melakukan kunjungan ke rumah sakit di Piru, pas kebenaran memang ya qadarullah ada pasien yang mengalami gawat nafas, sudah dicoba dilakukan, dibantu oleh Dr. Silvi dan teman-teman di sana dengan terapi standar, oksigen aliran rendah, kemudian kita coba dengan oksigen aliran tinggi, ternyata memang anaknya kondisi sangat berat, dan akhirnya kita diintubasi oleh Dr. Silvi, dan kita bantu dengan memberikan pengaturan tekanan ventilator. Jadi memang saat kemarin kunjungan itu luar biasa, karena kita dihadapkan pada real case, dan kami merasa sangat senang dapat membantu teman-teman di sana. Mudah-mudahan insya Allah anaknya tertolong sampai saat ini. Nah, kemudian yang terakhir, yang berikutnya adalah C, tata laksana untuk sirkulasi. Ya, kita memberikan cairan infus, memberikan jalur di mana kita berikan obat-obatan dan makanan, dan kemudian juga apabila ada itu tadi demam tinggi, seperti yang kemarin kita berikan tata laksana segera dengan obat-obat penurunan demam dan anti kejang. Nah, intinya adalah apabila terjadi henti napas, henti jantung, kita harus lakukan bantuan hidup dasar. Ini sangat penting karena salah satu akreditasi rumah sakit adalah seluruh tenaga kesehatan harus mampu melakukan BHD minimal, basic life support, ya, dan juga sampai ke advance, karena rumah sakit Laimena akan menjadi dan kita harapkan menjadi tipe A, tetapi saat ini pun merupakan top referral atau pusat rujukan utama, sehingga pemberian pembukaan jalan nafas, memberikan oksigen seperti ini semua harus dikuasai kemampuan ini oleh setiap petugas kesehatan yang berada di rumah sakit kita dan di seluruh provinsi Maluku tentunya kami harapkan. Dan ini adalah posisi di mana kita akan berupaya untuk menjaga jalan nafas atau pernafasannya tetap berlangsung baik, yaitu di mana anaknya berbaring, mendatar, dan kemudian dilakukan pembukaan jalan nafas seperti ini. Dan apabila denyut jantungnya di bawah 60 kali per menit, segera dilakukan chest kompresi atau pijat jantung luar yang sehari-hari kita kenal sebagai RJP, dan lihat bahwasanya sekarang posisinya apabila kita menolong harus dengan 2 tangan, tidak boleh dengan 1 tangan lagi atau 2 jari, ya. Itu adalah kebaruan yang sudah dideklarasikan sejak 2025 ini. Dan Devip, jadi ini sekalian Ibu Direktur, kami memberikan informasi sejak di awal bulan ini dari 2025, Guidelines Internasional dan Ikatan Dokter Anak Indonesia sudah membuat rekomendasi dan konsensus bahwasanya AED itu masuk ke dalam basic life support. Jadi untuk yang mengalami gangguan irama jantung atau cardiac arrest ya saat ini ya wajib diberikan dengan bantuan automatical electrical pemberiannya, di mana kita memberikannya ini sama seperti kayak kalau di bandara banyak bukan AED ya. Jadi hanya ditempel di pad saja ya. Jadi ini kita harapkan juga di rumah sakit ada dan dapat dikerjakan langsung untuk pada pediatric beds. Jadi itu kebaruannya. Jadi Bapak Ibu dokter-dokter sekalian, kami sudah membuat suatu rancangan konsensus bahwasanya saat ini AED masuk ke dalam basic life support ya. Nah, kemudian dilanjutkan apabila anaknya ROSC sudah return of spontaneous circulations, kita berikan bantuan lanjutan. Jangan ditinggal saja seorang bayi dan anak yang mengalami cardiac arrest atau henti nafas, henti jantung. Setelah kita lakukan bantuan hidup dasar, kita lanjutkan ke bantuan hidup selanjutnya atau advanced life support atau bantuan hidup lanjut berupa jika gangguan irama jantungnya masih terus berlangsung, wajib dilakukan defibrilasi ya. Nanti Dokter Eda dan teman-teman dokter anak dapat mengajarkan lebih lanjut. Kemudian juga akses vaskular, saya yakin ibu-ibu perawat jauh lebih jago dari kita dokter-dokter untuk mencari akses vaskular. Tetapi apabila tidak dapat dilakukan dengan perifer, kita akan ajarkan atau kita harus lakukan intraoseus ataupun akses vaskular sentral. Kemudian tata laksana jalan nafas advance itu tentu intubasi dan obat-obat emergensi lainnya. Apabila kita lihat guidelines dari luar negeri ya sangat rumit kira-kira, tetapi sebenarnya Ikatan Dokter Anak Indonesia nanti akan mengeluarkan konsensus terbaru mengenai. Dan apabila itu terjadi tetap gangguan irama jantung ya, jadi pada kondisi yang non shockable itu sejatinya obat-obat ini kami mengingatkan lagi pada Ibu Direktur dan jajarannya bahwasanya tolong obat-obat emergensi ini harus ada standby dok. Karena apabila tidak ada itu kita sangat sulit untuk memberikan perawatan tata laksana selanjutnya. Begitu juga untuk alat defibrilasi dan AED, karena untuk yang shockable rhythm itu dapat kita berikan dengan beberapa aturan saat ini, yaitu kita mulai dengan 4 joule per kilogram berat badan. Ya, dan ingatlah pada kondisi yang advanced life support, ingat ada 4H. Apa itu? Hipoksia, hipovolemia, hiper atau hiperkalemia, kemudian metabolik atau gangguan metabolik dan hipotermia. Mungkin Bapak Ibu, teman-teman sejawat sekalian, saat ini kita sedang diributkan oleh kasus salah satu yang menimpa teman sejawat kami dokter anak di kepulauan, ya kita tidak usah sebutkan, di mana kondisi yang terjadi adalah henti jantung tiba-tiba ya, yang sangat mungkin ya itu bisa terjadi juga pada pasien kita di hadapan kita. Jadi ilmu ini sejatinya sebaiknya harus kita kuasai dan kita tata laksananya juga kita harapkan yang tepat, karena bagaimanapun kita akan selalu berhadapan dengan kasus-kasus di mana mungkin terjadi hal-hal yang tidak kita inginkan. Jadi ingatlah bahwasanya pada kondisi kemungkinan henti jantung, henti napas ada 4 hal, yaitu karena kurang oksigen atau hipoksia, kurang cairan hipovolemia, kemudian gangguan elektrolit terutama hipo dan hiperkalemia. Dan 4T yaitu hati-hati terhadap kemungkinan pneumotorak atau pecahnya alveoli, ya pecahnya paru, tension pneumotorak, atau adanya tamponade, adanya cairan numpuk di dalam jantung, kemudian adanya zat-zat toksin dan trombosis. Ya, kami kira ini kita harus melakukan segera. Ya, ingatlah bahwasanya setelah dilakukan intubasi ataupun tata laksana lanjutan tetap diperkirakan atau di asesmen kembali itu ABCDE. Jangan lupa. Dan apabila sudah dilakukan upaya semua melakukan advanced life support atau tata laksana lanjutan, di rumah sakit itu tetap dilanjutkan pengawasan yaitu monitoring, kemudian optimal oksigenasi, kemudian tata laksana cairan, dan juga tentu sekali bahwasanya saat ini kita menekankan family center care. Jadi orang tua merupakan bagian dari tata laksana untuk pasien-pasien anak, sehingga orang tua akan merasa dilibatkan dan mereka tidak akan berpikir macam-macam, berpikir yang tidak baik tentang anaknya, karena dia akan melihat anaknya kondisinya sangat berat. Jadi mungkin kepada Ibu Direktur dan teman-teman sejawat lainnya bahwasanya family patient care ini saat ini kita optimalkan, kami rekomendasikan sehingga hubungan antara kita sebagai dokter dan keluarga pasien terjalin baik sehingga tidak menjadi tidak baik di kemudian hari. Dan yang paling penting juga post discharge, karena kenapa? Karena setelah pasien dirawat itu biasanya beberapa kasus terutama yang sangat berat yang lama dirawat di ruang PICU itu mengalami gangguan perkembangan. Itu banyak penelitian yang sudah kita lakukan di dalam Ikatan Dokter Anak Indonesia. Sehingga tata laksana lanjutan itu yaitu kembali ke poliklinik terutama untuk tumbuh kembang supaya tidak terjadi hambatan tumbuh kembang setelah gangguan kegawat daruratan selama dirawat di PICU. Intinya adalah pediatric life support itu sebagai keynote atau key message yang saya sampaikan, makin dini kita deteksi suatu kondisi kegawat daruratan, insya Allah makin cepat kita berikan tata laksana, akan makin baik hasilnya dan makin kecil gejala sisa, sehingga kita harapkan kualitas hidup bayi dan anak yang kita tolong itu baik. Jadi tidak sekedar menolong bahwasanya seorang bayi dan anak di PICU itu udah bisa napas, udah denyut jantungnya berdetak dengan baik, sudah. Yang penting seperti itu. Padahal setelah itu nanti anaknya, mohon maaf, akan banyak keterlambatan, nggak mampu bicara, nggak bisa berjalan, sehingga kualitas hidupnya kurang baik. Mungkin itu sehingga fungsi dari keluarga pasien tentu sangat kita perlukan. Sehingga makin dini dikenali makin baik tentunya pendekatan dengan PAT tadi segitiga, segi 5, segi 6 itu kalau kita lakukan rangkaian ini insya Allah itu akan dapat menurunkan angka kesakitan dan angka kematian bayi dan anak kita. Dan sekali lagi selalu ingat reassess kembali untuk dapat memberikan pelayanan yang terbaik. Demikianlah yang dapat kami sampaikan. Terima kasih atas kesempatan yang diberikan. Billahi taufik wal hidayah. Assalamualaikum warahmatullahi wabarakatuh. Salam Om Swastiastu. Terima kasih. Hotu meise. Thank you.
Yeah, thank you for your excellent presentation, Dr. Riri. Please take your seat on the podium. And then we go to the third presentation. Will join us today, Prof. Atsushi Kawajiki, MD, PhD. He is Professor and Division Director of Pediatric Critical Care Medicine Department of Pediatric, Saint Mariana University, School of Medicine, Kawasaki, Japan. Also Senior Research Associated in CHU Saint Justin Research Center, Department of Pediatric, University of Montreal, Canada. Yeah. So, Mr. Prof. Atsushi Kawajiki, MD, PhD, will presented about a milestone and a role of pediatric critical care in children health in Japan, and also will give us some information about how to use HFO. So, the place is yours.
Thank you, Dr. Eda. Good morning. Already 1 hour passed, and I guess you guys are so tired already. So take a deep breath now, okay? And stretch yourself if you want. And the next 50 minutes, 60 minutes, I'm going to talk about non-invasive respiratory support. We call it NRS, okay? Mainly about high-flow nasal cannula therapy, okay? Have you ever, I'm going to talk a little bit slowly, okay? And have you ever used high-flow nasal cannula? As you can see there, okay, there is a machine over there. It's called Airbo 2. Have you ever used that machine on your patient before? Anyone? So no. Okay. Never ever used before. Okay. So okay, just leave it there, please. Okay, so let me introduce myself a little bit. Uh, so I'm from Japan, but originally from Osaka, the west part of Japan, and I grown up in Nara city. It's the oldest capital, like maybe Jogja or I don't know anything about, but maybe like Jogja city in Japan. And half of my career was in Canada. Uh, you can see here, University of Alberta. I got PhD from there, and we had a first Nobel Prize in 2020 when this buildings launched, I think. And so the Edmonton, the city of maybe the one of the coldest city with 1 million population in the world. And I was there for 7 or 8 years, and I had a lot of friends from all over the world. And I moved to Montreal, is one of the most beautiful and cultural city in Canada. Uh, this is the right hand side of the gentleman here is my mentor, Dr. Philip Jubet. He is one of the leaders of AI, artificial intelligence, and CDSS. It's a clinical decision support system. Okay. So a lot of research is ongoing in Montreal, in Japan as well. And now I moved back to Japan 4 years ago, and I launched the PICU there. Okay, so to decrease the mortality of children with respiratory distress, what can you do? As Dr. Eder mentioned, okay, and the lecturer from here mentioned, 60-70% of children in Indonesia, okay, died with pulmonary respiratory disease, right? Infection. And that is the mortality rate is about 10 times higher than other, Japan or other developed countries. What can you do? Any ideas? A lot of things you can do: prevention, early detection, appropriate treatment, and social support, right? You may need clear water, electricity, Wi-Fi, 24/7 available, or prevention, immunization, or early detection, as Tomoya mentioned, and appropriate treatment, initial treatment or higher level of treatment, etc., etc. So I'm going to talk a little bit about the appropriate treatment, which you can probably apply on your daily practice from today. Okay. Again, NRS indicates non-invasive respiratory support. Okay. That might include nasal prong, mask O2, high flow nasal cannula that I will discuss later, NIV, CPAP. CPAP, I think everybody knows CPAP, right? Bubble CPAP. Anyone is from NICU? NICU, neonatal ICU? No one? Maybe two? Two of you? Two of you, okay. And have you ever heard bubble CPAP? Bubble CPAP, bubble CPAP. Yeah. Two. So you have two bubble CPAP. Okay. Anyone else? CPAP. No one ever used CPAP before? Only two in the island. No, maybe. Okay, so two CPAP at least. You know about the CPAP. Okay. And also, NRS may include any other other therapies like elbow therapy, like inhalation, nebulization, and helium, nitric oxide, etc. Okay. So first of all, I'm going to talk a little bit about CPAP. Okay. What is the CPAP? What is CPAP? No? CPAP. Yes, continuous positive airway pressure. Okay. Continuous positive airway pressure that can provide constant positive pressure throughout the breath, inspiration and exhalation. Okay. Delivered by non-invasive way, by nasal prong, mask, or helmet even. Right. So it's very complicated, but the physiology is very simple, very, very simple. And so I would like to try to make it simple, as much as simple. But how CPAP works in children, that can increase FRC. FRC, I'm going to talk a little bit about it later, but increase the functional residual capacity that you need to remember today, okay, at least. Prevent alveolar and airway collapse, reduce walker breathing, and improve oxygenation and ventilation. So what is walker breathing? During the talk of Tomoya and Dr. Liddy, both of them talk about the walker breathing. But what is walker breathing? What do you think of walker breathing? Are you yourself does have walker breathing? Yes, everybody, 24/7. During the sleeping time, during the day, everybody's. Now I'm working a little bit, not hard. Okay, my baseline walker breathing. I have a baseline walker breathing right now. That may increase with airway resistance. When I chew the straw, the airway resistance may increase. So that can increase the walker breathing to me, increase, okay? And lung chest wall compliance issues. If our lung is so stiff with COPD or pneumonia, or if you broken your ribs and chest wall, harder when chest wall is stiff, that can increase the walker breathing. Alveolar collapse, fatigue of respiratory muscles as well. Okay, and when we think about the walker breathing, that can be separated into two styles of walker breathing: elastic and flow resistive. Elastic means if the lung is very stiff, you need to make your walker breathing up, increase, right? You can imagine it very easily. Flow resistive. If you have phlegm, sputum inside of your trachea, yes, that can cause the resistance, increase the resistance, and ended up being having increased walker breathing. Very easy to imagine. So, if you provide CPAP on your patient, baby or infants or children, what kind of benefit are you able to provide on your patient? Okay, airway and alveolar stabilization. It's easy, very easy, right? Easy to remember. CPAP maintain positive pressure throughout the respiration. So can protect upper airway collapse or alveolar recruitment, right? And FRC. CPAP elevates FRC. FRC is, FRC is the lungs uh, capacity, lung capacity remaining at the end of your normal breathing. Okay, you're breathing. Okay, breathe in, out, breathe in, out. When you breathe out, normally the air remaining inside of the chest is called FRC. Okay, can you try that again? Try it by yourself. Now I have FRC, certain amount of FRC. Okay, if you breathe out forcefully, and then try to inhale again, try to breathe in again, you need to make more effort to breathe in, right? And then breathe in. You need to breathe in with more effort, right? Right. So if you have higher amount of FRC, that makes you breathe more easily, right? And CPAP also. So to be honest with you, the CPAP FRC effect is not being well studied over the last 2 decades, 3 decades, even after CPAP came out to our field. You know, it's not being well studied. And this is the study from 2022 using the rabbit, preterm rabbit. But that is actually in the case, the CPAP can increase the FRC like this here, right? Two more benefit from CPAP. Reduce inspiratory trigger load. CPAP offset airway resistance. Okay, CPAP can offer constant air. Constant air can get into the trachea. So when you breathe in, when patients start breathing in, okay, they can offset the airway resistance because of the air is coming in, and the air can push, right, offset. And the reduced diaphragm workload, that is one of the things needs to be studied more. So, and to some, without CPAP, you know, airway collapse and airway instability. With CPAP, airway resistance can be decreased. Alveolar decreasement can be achieved. FRC can be increased. Muscle workload can be decreased. Okay, that is the CPAP. So when you think about the CPAP, indication of the CPAP on your patient. So if patient does have higher airway resistance, okay, airway, and you want to make the lung liquided, or if patient does have increased vocal breathing, like Tomoya and Lily mentioned, and muscle workload, if patient looks tired, looks tired, you may be able to apply CPAP on your patient. Okay, next, high flow nasal cannula therapy. That is my favorite. Okay, CPAP actually, the high flow nasal cannula changed our practice a lot. It's a game changer. Okay, over the last 10 years, 15 years. When I started my fellowship in 2009 in Edmonton, that is the beginning of the high flow era. A lot of, this Airbo, so this is the Airbo 2, called Airbo 2 machine. Airbo 1 machine, Airbo came to the unit, and we started using. But before that, people tried to make a homemade style of high flow nasal cannula. Okay, high flow nasal cannula is not the high flow of the air. I'm gonna talk more details about. Okay, this is the picture when I tried in high flow as the very first time in almost 10 years ago in Washington, D.C. Okay, if you have a chance, please try it yourself. Very warm, heated warm air, like a tropical air coming into your trachea. Okay. And you'll feel better. For sure. Okay. So as I said, NRS or high flow it's been the game changer and everywhere. Okay. Our intubation rate is decreased a lot. Okay. Almost like 80% decrease, someone said. Okay, data when I got said. And also, this is the table from the UK, about 70%, okay, 70% of PQ patient is on the high flow nasal cannula or CPAP. Okay. And 80% of high flow bronchiolitic patient is on the high flow nasal cannula. Okay. So our practice right now in PQ cannot be operated with high flow right now. So this is a little bit old data, but the data from my unit in Edmonton. So since 2010, after the high flow nasal cannula machine coming into the unit, okay, for the respiratory disease, the use of NIV declining a lot, but the high flow had been used a lot more. It used to be like 20%, and over the 5 years, it increased up to 60%. Okay, I did a international survey about 10 years ago. This is a little very busy, but the data shows on the many different variety of disease and etiology. PQ physicians used high flow on those patients. Pneumonia, asthma, post-extubation, okay, upper airway obstruction like croup. They used high flow. That was the data from like 10 years ago. Okay. But to be honest, over the last 10 years, a lot of good evidence, RCTs, randomized control trial, and good evidence, clinical evidence has been emerged. So now is the time to create some guideline. That is, I am working right now with international colleagues. Hopefully in the next 2 years, we will publish the international guideline of high flow use. Okay. So physiology of the high flow is very important, very, very important. Please remember, remember five potential effect of high flow today. Okay. That is the only thing you need to remember today. Okay. Hopefully. So first thing, CO2 washout. CO2 washout, how can it achieve CO2 washout? CO2 washout. So as you can see here, okay, you can imagine the black dot as a CO2 particle. CO2 particle. So left-hand side is indicating no high flow nasal cannula. Breathe. Okay. When patient is not on high flow, end of expiration, CO2 particle occupied alveoli, trachea, and dead space everywhere, right? Inside of my mouth, the CO2, a lot of CO2 inside, okay? And when we breathe in, all the CO2 of the dead space here and inside of my mouth and the trachea pushed into the alveoli. Correct? Right. So CO2 particle, concentration of the CO2 particle is, as you can see, very high. But with high flow, you can wash out, high flow can wash out the CO2 particle inside of the dead space, inside of the larynx and pharynx and trachea, right? So that can make the concentration of the CO2 lower. That is the concept, basic concept of CO2 washout. So when your resident or fellows or nurses ask you why CO2 and why high flow nasal cannula can wash out the CO2, you need to describe this diagram, this figure, to explain how it works. Okay? Everybody understand? Okay, and then actually, this is the figures from the real human being. So CO2 can wash out. With the right-hand side is the 45 liters of the high flow can wash out the CO2 inside of the nair and larynx and pharynx. That's very obvious. Okay. So to wash out the CO2, how much flow you need to provide? How much flow you need to provide to the patient? Do you have a pen and paper and pen? No? If you have, or iPhone or whatever, a calculator. So imagine if you have 1-year-old bronchiolitic patient, okay? Respiratory rate generally increased, okay? And tidal volume decreased and exhalation time is up, in generally speaking, okay? 10 kilo, RR is 40, respiratory rate is 40, tidal volume 60, and EI ratio, okay, is 40:1. Okay, so within 1 minute, 60 seconds, this patient needs to breathe 40 times. So 60 divided 40 can gives you 1.5 seconds per breathe. Easy, right? Anyone is following me? Okay. Easy math. 1.5 seconds times, okay, 20%. EI ratio is 40:1. So this patient needs to breathe in 60 ml of air in 0.3 seconds, right? Easy. So inspirating 60 ml in 0.3 seconds. So 60 ml divided by 0.3 can gives you 200 ml per second of flow rate. So this baby, 10 kilo or 40, inhale, breathing in the air with this, this rate, 200 ml per second. So 200 ml is 0.2 liters per second times 60 seconds divided by 10 gives you 1.2 liter per kilo per minute. This is the inspiratory flow of this baby, okay, theoretically. Okay, so if you can give more than this flow, theoretically you can wash out all the dead space air. This patient, all the air coming in to the nair is replaced with the flow from high flow device, right? So 100% CO2 can be washed out in the dead space. Understand? Okay. So provide a flow rate. So if this patient is breathing faster, 80 per mil, 80 times per minute. So that can increase the flow rate of this baby, 2.4 liter per kilo per minute. It's the minimum flow. You can imagine if patient is breathing faster, right? So the inspiratory flow rate should increase a lot. So good to remember to start with. Okay, when you apply high flow nasal cannula on the patient to wash out the CO2, you should probably start from 1 or 2 liter per kilo per minute as a tentative rate, tentative guide. Okay, remember it. Okay, so if you have 20 kilo, infant of 20 kilo, you should start from 40. Okay, 2 times 20. So this is the amount of CO2 can be washed out in a bench study. Okay, so here the CO2 washout effect. CO2 can be washed out about 20% to 30%. Not all of the CO2 can be washed out, sure. The CO2 in the dead space, our dead space, can only be washed out by CO2, right? So only 20%, 30% of the CO2 can be washed out. It's not a lot of effect, but if you are very much concerned about the CO2, ventilation, you can apply high flow as a CO2 washout machine. Okay. So, okay, one more thing. So someone asks you, when patient is on high flow, this patient needs to open his or her mouth or not? Okay. Some of our nurse says to me, if baby is crying on high flow, can they apply the nipple on his mouth to try to make him not crying? No, stop crying. Okay, so if you want to wash out CO2 better, try to keep the mouth open. Try to keep the mouth open anytime. Okay, when patient close the mouth, or if you intentionally close or occlude the mouth, CO2 washout effect may decrease. Okay. And number 2 is higher concentration of the CO2 can be offered to the patient. It's the opposite. It's opposite from the CO2 theory. So theoretically, it depends on the body weight. It depends on the body weight and the lung capacity. But theoretically speaking, we can provide close to 100% of FiO2 on the children, but not to the adult patient. To the adult patient, the maximum flow we can provide currently on this machine is 60 liters per minute. So with 60 liters per minute of airflow, you cannot provide 100% of FiO2. Okay. That's because our breathing flow is above 60 liters per minute. Okay. And the number 3 is, I think it's the most important effect of high flow, heated humidification of the air. Okay. So when you breathe in the air, here, maybe this room, the humidity is about maybe 30% of something. It's very dry. But when you breathe out, all of the air you breathe out is moistured, very moistured and hot. right? So your inside of your membrane, the tracheal membrane is 100% moistured anytime. So it's on a very good condition. You should not ignore the downside of the dry air or cold air. This is the data from, this is the data showing when we provide dry, cold air continuously on the patient or mouse, a lot of cells, damaged by the air, even the dry air, just with the dry air. Okay. And as I said, when we breathe in the air, dry, cold air, our body try to heat and humidify the air a lot. That is called air conditioning. Okay. So a lot of happening inside of your air. When you breathe in, all the air, even if you breathe in 30% of humidity of the air, your body try to humidify the air up to 90 to 95%. Okay. And every single breathe. Okay. And also now in Tokyo is about like 5 degrees Celsius. So our body needs to heat the air every time, every day. But here is very good for health, I think. You don't need to use a lot of energy, right? So try when you need to heat and humidify the air, you need to use a lot of energy. Okay. You don't need to remember this, but when you breathe colder, drier air, you need to use more energy. Patient needs to use more energy. So remember, in your NICU, maybe the premature baby is in the incubator, right? Very small baby is in the incubator. Why? It's not only to try to keep the temperature up, but the moisture and temperature is the most important. If they come out from the incubator, they are exposed to the dry, cold air because the PICU, in generally speaking, it's in the air conditioning. Maybe 25 or 26 degree of this room, the temperature is about 26 degree. Okay. So that is not good for baby. And again, you don't need to remember it, but this is the calculation based on this formula. But if you breathe in 23 degree of temperature of the air and then try to humidify the air to 100% from 50%, this baby, that baby, 10 kilo broncholytic baby, needs to use 6 kilcal per hour. Okay. In total, 144 kilcal per day. So basic metabolism of the infants, this infant is about 700 to 900 kilcal per day. So you can imagine about 20% of energy, okay, is used just to heat and humidify the air every day. Every day. It's a lot. So if you can give moistured, heated, well humidified air, that can decrease the workload, energy consumption of the baby a lot. Okay. And the last one is PEEP effect. PEEP effect is, you don't need to remember the PEEP effect. It used to be discussed a lot, PEEP effect. Okay. PEEP effect is when you increase when you give a flow, someone may say, okay, that can increase the FRC, that can provide speed. Yes, that's true. When the baby is closing his mouth, yes, we can provide some certain amount of teeth. Okay? That can increase by increasing the flow rate as well. But remember here on the right-hand side of the diagram showing about 2 liter per kilo per minute of flow can only provide about 4 centimeter mercury of the water of pharyngeal pressure. PEEP should be lower than that. So PEEP effect is minimum that you need to remember. Okay. The other benefit of high flow is indicated here. Risk of facial deformity due to long-term wearing is very small as compared to CPAP. Easy nasal and mouth suctioning. Okay, it's very easy to suction. Better patient compliance as compared to CPAP or mask. Oral medication, oral feeding is easy to provide. Okay, you can remember with this high flow, heated, humidified, inspiratory demand, okay, functional residual capacity can be increased. Its minimum effect, lighter, more easily tolerate than NIV or CPAP. Okay, easy compliance, better compliance, etc. Oxygen dilution can minimize oxygen dilution in the case so you can provide higher concentrated oxygen, washout of dead space, CO2 washout, high flow. Okay. So I'm going to show some of the evidence we have in pediatric field, the next couple of slides, but please remember the 5 effect, high flow effect, no CO2 washout, high oxygen concentration, PEEP effect, heated humidification, energy consumption. Okay. One of the other thing is stenting effect that is very not well studied, so I'm not gonna touch about it. But anyhow, when you think about indication, if you think maybe we should start high flow on new patient, think about the indication or theoretical indication first. Okay. Please do not use high flow without thinking physiological effect. If you want to decrease the patient workload, breathing workload, if you want to wash out the CO2, if you want to provide higher amount of oxygen, you can start high flow. But if there's no other indication, please do not use high flow routinely. Okay. When my fellow comes to me and said, okay, doctor, I just started a high flow on our patient, I'm always asking, why? What is your rationale? Why you started high flow? Okay. Think about it. So as I said, high flow just emerged about 15 years ago. And over the last decade, a lot of evidence came out. Okay. So a lot of evidence, compared O2 and high flow. On the pediatric ward, PQ, emergency department, on asthma, bronchiolitis, pneumonia, a lot of studies been done. Okay. So I don't have much time, so I'm going to skip them. But generally speaking, if your patient is working harder in PQ, okay, high flow can provide some benefit on your patient as compared to standard O2. Okay. So this is the study. If you can read English without any difficulties, please read this paper. Came out about 2 years ago. Okay. It's called Fast ABC. One of my friends in the UK did this study as a PI. And this include all the patients in the UK with respiratory distress, children with respiratory distress. Not about the asthma, not only on pneumonia, etc. All the respiratory distress, the patient. Okay, it's compared to CPAP. Okay, compared to CPAP, 7 to 8 centimeter water. Okay, 2 liter per kilo per minute of high flow versus CPAP. And we know that from the previous studies, we know that CO2 can provide better PEEP, for sure, better PEEP. But we also know about the benefit of high flow as well. High flow can provide better compliance, easy to suction, okay? And maybe doesn't need much sedation as compared to CPAP medication. So bottom line is CPAP is slightly better than high flow, but as compared to standard O2, standard O2 is conventional O2 therapy. As you can see here, and this is systematic review, the result of the systematic review compared with COT, conventional O2 therapy. CPAP and high flow can decrease the worsening of likelihood of worsening of respiratory disease, respiratory conditions. Okay, that is confirmed. So when your patient is struggling, showing increased vocal breathing, you can try high flow or CPAP, whichever you have, whichever you are very comfortable to use. Okay. And if you start from high flow, okay, and it seems it doesn't work, you can escalate the therapy to CPAP, high flow CPAP. Okay, this is a very good diagram you can follow. Okay, after you recognize your patient respiratory distress, okay, you can start from standard O2 therapy. Standard O2 therapy meaning nasal prong, mask, or reservoir mask, whatever. Okay, but that is just the oxygen. It not doing anything, just O2. Okay, and then if patient is struggling still, you can start high flow CPAP or BiPAP as an NRS. And eventually, if patient failed with NRS, you can escalate into invasive mechanical ventilation, meaning you need to intubate the patient. Okay. Okay. And then after that, after extubation of the patient, you can use NRS again before putting on to the oxygen standard O2. This is also very good diagram you can follow. Okay, it's publicly available, BMJ Open. You can just Google BMJ Open 2020 10 blah blah blah, and this is the diagram used. I mean the guide used in first ABC study. It's a standard of UK. Okay. So this is only indicating after starting the high flow. Starting the high flow, when you think about the CPAP, blah, blah, blah. So in my practice, or in the UK after the first ABC study, okay, start high flow first. Then evaluate the patient within 1 or 2 hours. If patient doesn't show any sign of improvement, decreasing the heart rate, decreasing the respiratory rate, please do not continue high flow. Escalate NRS into CPAP or NIV. Okay, without any hesitation. And of course, you may need to think about the cost, transport, etc., etc. But if you have everything on your hand, please not to hesitate to increase to NIV from high flow. If my resident or fellow says, "Oh, I started a high flow 8 hours ago," patient can maintaining saturation, breathing pattern looks the same. So I'm gonna say, okay, stop high flow. I'm gonna be mad. Okay. So a lot of so this slide can be, I think, shared to you all later. So I mean, I'm not gonna read everything, but a lot of good things and bad things as well. Okay, this slide is Tomoya also mentioned in his talk, but there are a few tips I would like to share with you. 5 more slides, so no worries. I'm going to stop soon. So, high flow can give the patient higher concentrated O2. So, can mask the desaturation or oxygen condition. This is the very typical vital sign trend with respiratory distress of kids. Okay, you can see here the left-hand side. Initially, when patients start working harder, respiratory rate or VE indicates tidal volume, breathing deeper, faster, and CO2 initially dropping down. Okay, and then respiratory rate, tidal volume increasing, and all of the sudden, drops. We need to avoid this. You should hear, listen, the voice of the children every time. When patient breathing faster, deeper, okay, maybe something happening. Do not trust CO2. Okay, blood gas sample result doesn't matter. Forget about it. Okay. And again, so how we can we follow the SpO2 saturation values to think about the effect of high flow? How we can use it, saturation, for the evaluation? A lot of index has been published. One of the index widely used is LOX index now. Saturation divided by FiO2 divided by RR, respiratory rate. And of course, this cannot be applied for children. Children of 1-year-old, 10-year-old, does have a different respiratory rate, right? So one of the Thailand colleagues published pediatric LOX index. So you can follow maybe, but my point is that saturation, you should not follow only saturation. FiO2, how much FiO2 is some patients on? Respiratory rate as well. If patient breathing rate start decreasing after applying high flow, that is your success. It's a success. If you can decrease the FiO2 after applying a high flow nasal cannula, you win. Okay. Okay, and some more tips. So in Indonesia, actually, this is my first time Indonesia visit, and I visited many places in Sumatra, Java, and many hospitals, provincial hospitals. And I saw, now we have here Airport 2 and the Hamilton T1 is the mechanical ventilator for mainly for transport. And also COV-19 is the Indonesian-made high-flow nasal cannula machine is widely provided in all of the country over the last 5 years. Okay. And also we have J-Flow. It's a Japan-made the portable high-flow nasal cannula machine, and each has the good and bad things, okay, pro and cons. I'm gonna go through slightly. So transport use, yes, it's a transport. Hamilton T1 is the machine you can use it for transport, but it's very heavy and expensive. Okay. And the JFlow is another option, but Airbo 2 and COP19 machine is only for intra-hospital use. Okay. Power and Batley, Airbo 2 and COP19 can be provided with AC conditions. Hamilton T1 is the good for long distance transport. JFlow is currently only last the Batley for 1 to 2 hours. Cost is a big issue, and but the JFlow include SpO2 and heart rate monitor on the machine as well. Hamilton is the perfect for that can give us every single parameters of ventilation. Okay, the usability. The JFlow is the only machine with the usable parts. Okay, so that can make the cost lower. Maintenance is the Hamilton T1 is very complex to be maintained. No, I don't know anything about the background of the Hamilton T1, and Airbo 2 is very easy. JFlow as well. COVID-19, I don't know how much the parts or it can be maintained under the maintenance of the 24/7 available team. We don't know, but the Airbo 2 is quite easy. Okay, so I'm gonna just compare the two devices. One is the Airbo 2. You can set up like this, with oxygen, and a power generator on the bottom. And you need to have the Airbo 2. I'm gonna show you later if you have time. And then you need to plug in to the generator. Okay, Airbo 2, JFlow is like this, very portable, very light, and easy to carry on. Okay, so this is all I have. And after the session, I'm gonna give you some session to show how to use the Airbo 2, how to set up the Airbo 2. If you have time, please come closer later. And yeah, that's all I have. Thank you so much.
Give a big applause to Prof. Akatsushi. Thank you for your excellent presentation, Prof. For the conclusion, the high flow use is very useful for every children who have a very for the diagnosed patient with respiratory distress. Jadi saya pakai bahasa aja ya. I use bahasa, Prof. Ya. Jadi kegunaan HIV ini sangat penting sekali ya teman-teman. Kalau misalnya teman-teman sekalian pernah lihat CPAP, pernah menggunakan CPAP ya, kebanyakan CPAP digunakan kan untuk bayi-bayi prematur ya. Nah, CPAP itu dia gunakan untuk membuka alveolus supaya alveolusnya tidak kolaps. Ya. Nah, jadi itu nanti kalau kita mau perbedaan dengan HFO itu dia membuat kalau macam misalnya ada bayi atau anak-anak yang lagi sesak nih, ya, sesak sekali sampai napasnya itu kadar CO2 dalam tubuhnya itu kan sangat tinggi, ya. Jadi kalau kadar CO2 tambah tinggi dalam dia punya badan atau dalam sirkulasi sistemiknya, itu dia bisa bikin asidosis dan kontrol metabolik anak itu dia akan lebih jelek, ya. Nah, jadi dan kalau kita cuma pakai CPAP saja, itu dia tidak membuat konsentrasi oksigen dalam tubuhnya itu lebih tinggi, ya. Nah, jadi kalau macam misalnya ada anak-anak yang dalam keadaan distres nafas ya, kita menggunakan HFO, itu kadar CO2 itu kita bisa buang. Jadi oksigen yang bisa masuk ke paru-paru itu akan lebih banyak. Jadi kalau macam misalnya kita pakai HFO, konsentrasi oksigen yang kita butuhkan itu jadi lebih tinggi. Terus kita pasti kadang tuh saya lihat teman-teman perawat di PICU, kadang mereka tidak menghidupkan humidifier ya. Padahal humidifier itu sangat penting ya, apalagi kalau bayi-bayi yang lagi distres nafas, karena pada saat distres nafas itu ya kalau kita tidak menghangatkan udara ke paru-parunya, itu efeknya ya kalori yang ada dalam tubuhnya itu dia gunakan untuk menghangatkan udara yang akan masuk ke paru-paru, akhirnya gula darahnya drop, hipoglikemi, pasiennya kejang ya. Jadi jangan pernah menyampingkan itu humidifier, harus dinyalakan ya, karena sangat penting untuk proses penyembuhan daripada pasien itu sendiri. Karena kalau tidak dinyalakan, itu bayinya lama-lama nanti dia menggunakan semua kalorinya untuk menghangatkan dia punya hidung supaya dia bisa konsentrasi oksigennya bisa lebih tinggi. Jadinya memang kadar oksigen di monitor itu dia bagus, saturasinya 100%. Namun tiba-tiba bayinya tiba-tiba kejang. Karena kan pernah teman-teman hadapi seperti itu ya. Nah, oh ini saturasinya bagus, anaknya memang nafasnya sesak, tapi tiba-tiba dia kejang. Bisa jadi karena dia kurang gula. Pas kita periksa, oh gula darahnya drop. Karena ternyata humidifier pada saat kita gunakan alat kayak NIV, CPAP, itu tidak dikasih menyala. Ya. Nah, jadi kalaupun misalnya ada teman-teman yang ingin bertanya mengenai bagaimana menggunakan HFO yang benar, tolong tanyakan ke Prof, nanti kami terjemahkan. Ya, jadi jangan takut, terutama untuk teman-teman yang perawat, dokter ya, dokter spesialis anak. Nah, saya juga banyak ilmu yang saya dapatkan di sini sambil saya jadi moderator, saya belajar. Ya, ya, itu. Thank you, Prof. There is a lot of thing I have learned about your presentation, and it's very useful for us. So maybe I call for 3 presented to come here in the podium. So we can start our answer and question session. Yeah. Take a seat, please. Dr. Tomoya, please. Kemudian tadi juga yang dijelaskan oleh dokter ini sangat penting ya, terutama buat teman-teman perawat ya, dokter yang lagi jaga di UGD. Kita menggunakan segitiga triangle ya, segitiga gawat daratan anak ya. Dengan itu kita tidak perlu pakai stetoskop. Kalau macam misalnya adik-adik yang jaga di UGD nih, ada pasien masuk dari UGD dengan sesak atau penurunan kesadaran ataupun dia normal pun, teman-teman sudah bisa tahu, oh ini dia masuk triase hijau, oh ini dia masuk triase kuning, oh ini dia masuk triase merah, ya. Teman-teman perawat juga langsung bisa pilih. Tiba-tiba nanti dibilang BPJS bilang misalnya ada pasien BPJS, teman-teman bilang kata, oh ibu tidak boleh masuk di sini karena ibu bukan orang pasien emergensi misalnya, pasti kan pasti bakal lain keluarga pasien toh. Nah, dengan PAT ini ya, teman-teman sudah bisa bilang, oh ini kami punya standar ini PAT ya. Jadi kalau Bapak dengan Ibu punya keluhan ini, mohon maaf anak-anak ya, anak. Nah, jadi ini Ibu punya anak ini, kalau macam misalnya dia punya keluhan yang ada di segitiga ini, berarti Ibu mau anak itu masuk kriteria yang hijau. Jadi Ibu punya anak yang perlu masuk di UGD, harus ke rawat jalan. Nah, itu sebagai pegangan kita juga supaya jam bakalai dengan keluarga pasien, ya. Pasti yang jaga-jaga di UGD semua punya merasakan hal yang sama ya. Iya, seperti itu. Ya, jadi teman-teman apabila ada pertanyaan, silahkan bertanya, jangan malu-malu. Ya, silahkan. Kalau ada yang di Zoom, ada yang mau bertanya? Oh ya, ini satu. Ya, he use English, Prof. This is Yayan Mahendro. Ya, halo Yayan. Ya, Yayan nih. Halo Yayan. He is our ex worker here. Now he stay in RSUP Surabaya. He mutation in there. Ya, ya. Maybe apa namanya bisa ini dikasih ini pertanyaannya supaya saya bisa lihat. Chatnya ditekan Kak. Atau Yayan mau bicara langsung Yayan? Oh tidak. Jadi jauh-jauh ya dari RSUP Surabaya. Ya Alhamdulillah terima kasih ya Yayan ya. Chatnya dibuka tolong Kak. Ya, ya saya lihat lewat ini saja dong. Kalau susah. Oh, saya tidak kelihatan nih karena saya baru buka. Atau saya bisa pinjam laptopnya? Atau ada dari teman-teman di ruangan yang mau bertanya? If any question, ya, ya silahkan ya. Silahkan Mas Joko. Ya, pakai bahasa Inggris ya. Ya.
Thank you. What a very impressive presentation from our speakers, Dr. Tomoya, Prof. Atsushi, and Dr. Riri on neonatal respiratory case and example how to manage them. Thank you for coming to Molucas, and I hope you enjoy your time and felt welcome here. I also hope you will visit us again in the future. And please allow me to ask the question. And my question is there a relationship or connection between extremely low birth weight and respiratory disorders? If you believe they are related, then how we determine which condition should be considered the primary diagnosis or the main issues to manage the patient's care? Because we are currently having a different opinion with our insurance system regarding which diagnosis should be as the primary diagnosis or which one should be a secondary diagnosis, because each carries a different claim values. That's my question. Thank you.
Prof. Maybe because our apa namanya questioner is from coding in for insurance. So he always find a problem with a doctor about how what is the is bigger urgency about extremely low birth weight or respiratory distress for taking that diagnose is head diagnosis because is very influence the claim of the insurance. But saya pakai bahasa Indonesia mungkin karena ini kan beliau ya apa namanya intensivis ya Joko ya, bukan beliau juga tidak mengetahui bagaimana proses klaim insuransi di Indonesia. Ya, jadi untuk masalah klaim insuransi dan lain sebagainya mungkin nanti ditanya ke Dokter Riri saja ya. Ya, karena tidak sama proses klaim, tidak ada BPJS di Jepang ya. Ya, jadi apa namanya beda cara insuransinya. Jadi mungkin Dokter Riri yang akan menjelaskan dan karena ini Joko bertanya mengenai NICU ya BBLR, Dokter Riri ini beliau adalah PICU. Jadi untuk diagnosa BBLR itu beliau tidak menangani seperti itu, tapi beliau akan coba jelaskan ya. Dari profesor juga mungkin beliau akan memberikan pandangan perbedaan antara sistem insuransi di Jepang dengan di Indonesia untuk pengklaiman mungkin ya. Ya.
I'm not sure I got your point, but to be honest and generally speaking, in all of the world right now, in neonatal ICU, high flow nasal cannula has been more and more used right now for premature baby to avoid intubation. Okay, so intubation rate of premature baby right now is almost like 20-30% as compared to 10-20 years ago after high flow nasal cannula coming into our practice. I'm not the NICU doctor, but NICU now is quite rare to see the intubated patient. So that is mainly due to the high flow. So they sometimes use the high flow for, of course, increased vocal breathing due to prematurity. Okay, RDS or pneumonia, meconium aspiration, whatever the reason is, or with or without prematurity, if baby in NICU does have increased vocal breathing, a lot of NICU doctor now choose to start high flow instead of intubating immediately. That is the practice right now with high flow. So if more and more people start using high flow, I'm sure you're gonna be in trouble. Right? So, but the important thing is that high flow is not for disease, it's for condition. Okay, condition of increased vocal breathing or tiring of the muscle fatigue, etc., etc. So, it doesn't matter what kind of disease this patient have. Yeah. So as I shown there, my slides from 10 years ago, the survey, many PICU physician use the high flow on pneumonia or croup or whatever. So croup, ARDS, everything. So yeah, so it's very complicated when you think about the reimbursement, but yeah, that's my answer. I'm not sure I'm answering to your question.
Thank you, Prof. Atsushi. Saya bisa, please let me explain in Indonesia. Untuk diagnosis extremely low birth weight dengan extremely respiratory distress, ya physiologic by very very preterm itu memang nafasnya cepat. Kenapa? Karena parunya kecil, volume alveolinya kecil, sehingga untuk memenuhi kebutuhan oksigennya dia akan meningkatkan rate-nya. Jadi laju napas bayi itu emang kenceng, memang cepat. That's physiologic. Jadi kalau mau pikirkan diagnosis extremely low birth weight dengan respiratory distress, jadi harus ada tanda-tanda sign respiratory distress lainnya, bukan hanya laju napas. Jadi kalau untuk menunjukkan diagnosis untuk claim, tentu yang paling tinggi adalah extremely low birth weight. Apakah dia ada human membrane disease, apakah ada pneumonia, dan biasanya kalau sudah pakai ventilator itu high membrane disease itu bisa dibuatkan yang pertama atau menjadi RDS, respiratory distress and neonate. But honestly, we are not neonatologist. Maybe kalau ada yang neonatologist bisa bantu lebih jawab.
Jadi saya bantu menjawab saja, Dok. Mungkin karena apa namanya selalu di ini bahwa saya pasti mengerti Joko punya perasaan bahwa ini pasiennya masuk dengan sesak, tapi bayinya kan bayi prematur ya. Kok saya harus dokter-dokter itu suka sekali diagnosa utamanya itu harus extremely birth weight. Nah, kenapa tidak RDN? Karena kan dia masuk dengan sesak, begitu ya, Joko ya. Ya, jadi kita tahu bahwa bayi prematur itu dia belum waktunya dia harus lahir di muka bumi ini. Jadi segala bentuk organ-organnya itu dia belum matang, baik otaknya, kemudian jantungnya, paru-parunya ya. Jadi karena belum matang itu ada namanya surfaktan ya di dalam dia punya paru-paru, dia akan terbentuk pada usia 34 minggu ke atas. Ya. Nah, kalau dia di bawah itu dia akan sangat sempurna apabila dia sudah cukup bulan yaitu 40 minggu. Ya, nah, kalau misalkan bayinya dia lahir sebelum 40 minggu, artinya dia kurang ya surfaktan itu. Sedangkan surfaktan itu dia bertugas supaya paru-paru itu jangan kolaps. Ya, nah karena dia kolaps itu, karena surfaktannya belum terbentuk, makanya kalau bayi-bayi BBLR atau bayi-bayi yang prematur itu dia gampang sekali sesak. Ya, jadi penyebabnya itu adalah karena dia bayi prematur dan bayi BBLR, makanya diagnosa utama yang kami sering gunakan untuk awal itu adalah BBLE extremely birth weight seperti itu. Jadi karena bayinya itu dia prematur, makanya dia gampang sesak. Nah, itu adalah penyebab utamanya bayi prematurnya, ya. Nah, jadi tadi Prof. Tomoya juga sudah menyampaikan apabila kalau macam misalnya ada penggunaan HFO untuk bayi prematur, mungkin klaimnya itu lebih kecil ya dibandingkan dengan ventilator. Tetapi penggunaannya itu kita harus tetap gunakan sesuai dengan indikasi medis. Ya, mungkin itu bisa menjawab ya Joko ya. Ya, terima kasih. Mungkin Joko mau mendengarkan bagaimana insuransi di Jepang dengan di Indonesia? Boleh? Ya, ya. Prof, ini ya the Joko he wants to know about insurance in Japan and insurance in Indonesia. In Indonesia we calling BPJS. Yeah, BPJS is one of national insurance in Indonesia. He provide us with health care for the patient like that.
So the long story, but generally speaking, Japan has a universal healthcare system. Okay, the universal healthcare coverage to everybody, and depends on where you live, depends on the municipal you live. But generally speaking, under 15 years old, all the healthcare cost is free, basically free. Yeah. So and the patient doesn't need to pay anything. Yeah, but depends. So the city where I live, West Tokyo City, is only 300 yen. It's about 30,000 rupiah is the maximum to pay parents to pay for prescription. prescription per time. So, but all the healthcare costs and the physician visit and everything is free, basically covered by the insurance. The insurance, it's not the unique thing. So there is a so-called, I'm a physician in the private medical university, but the healthcare system is one umbrella, under one umbrella. Okay. So our salary remuneration from the university, about 20% to 30% of my salary is going to the insurance, to maintain the insurance. Okay. So maintaining the healthcare system, universal healthcare system. So we started it 70 years ago. Indonesia universal healthcare system only started in 10 years ago. That is my understanding. So maintaining the healthcare system is very difficult, actually, very hard. And regarding the high flow nasal cannula, okay, it's covered by the insurance for sure. Okay, as long as it's used, high flow nasal cannula is used for appropriate way. I mean, appropriate way meaning under the regulation, the disease list or the length of use, etc. Like ECMO, ECMO is the extracorporeal membrane oxygenation. It's strictly controlled by the law. So if we use it, let's say, any other things, IVIG, immunoglobulin used for Kawasaki disease, okay, we cannot use it for more than 7 days per month. If we want, or if someone wants to use it, physician wants to use it for longer than 7 days or 14 days, etc., hospital needs to pay. But parents doesn't need to pay. Hospital needs to pay to the government, to the municipal healthcare officer. Okay. Yeah. So it's very strict under regulation, but it's been built up over the last 70 years. So everyone is like physician now. I have a very big role to complain to the government as a part of the member of healthcare insurance system in the Japanese Society of Intensive Care Medicine. So every 2 years, we ask, or we give a request to the government to manipulate, to make it better, or make it like a better fitting to our healthcare. Right? High flow nasal cannula was not on the list 20 years ago for sure, but it's now listed.
Yeah. Thank you, Prof, for the answer. How about that, Joko? Is okay? Oke. Jadi saya pakai bahasa Indonesia ya. Alhamdulillah kalau di Jepang itu biaya asuransi itu dia semuanya digratiskan ya untuk masalah kesehatan ya. Nah, kalau kita belum ya, nah kita harus pakai BPJS. Jadi kalau di sana warga negara Jepang itu gratis untuk masuk di rumah sakit untuk berobat ya. Terus bagaimana sih misalkan ada penyakit Kawasaki ya, penyakit Kawasaki. Nah, ini penyakit Kawasaki ini kan dia butuh IVIG, imunoglobulin itu hanya ditanggung itu sampai 7 hari saja. Kalau digunakan sampai misalnya lebih dari 7 hari, berarti rumah sakit yang harus membayar ke pemerintah. Ya. Kalau kita di sini kan pasien yang harus menambah, tidak ya? Tidak, tetap harus dibayar sama rumah sakit. Ya, jadi memang sebenarnya sama saja, tapi memang rugi ya, rugi di rumah sakitnya. Nah, tapi memang agak beda karena Jepang kan negara kaya. Kalau kita ya belum lagi mau bayar dokternya sama uangnya, belum lagi mau bayar perawat, belum lagi mau bayar yang lain-lainnya. Kalau tidak ditunjang dengan klaim yang pas, rumah sakit bisa rugi. Seperti itu. Bisa kolaps, tutup ini rumah sakit ya. Itu maksudnya mungkin Joko dong. Ya, mungkin ada pertanyaan yang lainnya? Oh ya, oke. This is a question for Yayan Mahendroko, our ex-worker, our good morning, Dr. Tomoya. Yeah, this is a question for Dr. Tomoya. Yeah, I'm Yayan Mahendroko, and I'm a nurse from the NICU team. I'd like to ask for your insight regarding family-centered care. Yeah, in your perspective, what is the best way for the healthcare team to meaningful and effectively involve parent in the care plan of critically ill child, especially during intensive care treatment? Thank you. Yeah, maybe he from NICU, but you can answer when you're in a PICU. Thank you.
Thank you for your comment and question. Yeah, 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 yeah. And as you about family-centered care, and as you know, as I said, becoming more and more important, more crucial matter, and in both in NICU and PICU. There's no specific answer from my perspective, and I have two recommendations. One, the giving sufficient information to the family and parents or as members. And this is because sometimes parents and families have not enough information, and so mentally, physically get tired out. And second is, if possible, we should do a two-team and practical treatment team and communicating with the family team. This often helps the Greece and workload and for both and healthcare members and family other members. Okay, that's my perspectives.
Thank you, Dr. Tomoya. Yeah, maybe Dr. Riri or Prof. Arsusi will add.
Yang, I believe you can hear me, but so it's a very hot topic in our field right now. FCC, family-centered care, is very hot and very well studied over the last decade. And we have discussed a lot in Japan as well. And the North America is way beyond from us, from my perspective. And so what you should begin with, is to share the value, okay, value of the FCC first. Okay, you need to find out what you can do. Okay, what you can do in your unit. It depends on the unit, depends on the size of the unit, depends on the patient background or parents' background, etc. You don't need to follow everything from North America or other society. Okay, but the most important thing to begin with is to share the value with the team first. What is the good thing, bad thing to the family and parents, family and children? Okay, every time it's in NICU, it's called family-centered care. But I don't like this terminology. Actually, we should put kids, baby in the center. Okay. Children-centered care with family is the thing you need to think about all the time. That's my value. Okay. And also, you need to share the privilege. WHO, UNICEF actually declared the child lights in the hospital. You can share with your colleague of the statement from WHO. Okay, children does have a privilege and rights to be cared by parents, to be with the parents all the time. So think about it. and think and no, create your family-centered care situation in your NICU. That's my message.
Maybe I can add and present it in bahasa. Please allow me. Bapak Yayan dan mungkin teman-teman dan dokter sekalian, family center care kita memang mulai baru menggalakkan seperti Prof. Atsushi bilang, kita nggak perlu mengadopsi semua yang dari Amerika atau yang dari manapun negara lain kalau memang kelihatannya itu tidak terlalu cocok untuk kita. Tetapi family center care seperti tadi disebut di Indonesia sejatinya nggak usahkan kita bilang family center care. Sebenarnya sejatinya tata laksana pasien kita di Indonesia itu selalu melibatkan keluarga, bukan? Ya, saya nggak tahu, saya kan dari Sumatera ya, tapi saya kira sama ya. Kalau ada anggota keluarga yang sakit, itu mungkin satu RT suka datang gantian gitu kan, bahkan suka camping di depan kamarnya begitu. Saya nggak tahu kalau di sini begitu. Tapi intinya adalah keluarga selalu apalagi pasien anak gitu ya, mereka ingin dilibatkan. Dalam hal ini kalau intensive care ada beberapa keterbatasan karena intensive care itu adalah unit khusus di mana anak-anaknya kan sudah sangat sakit sehingga semua peralatan medis dan lain-lain itu memang harus dimonitor. Apabila ada keluarga sering bolak-balik masuk, kemudian duduk di situ atau itu mungkin bagaimanapun akan mengganggu pekerjaan atau bagaimana mengganggu aktivitas kita dalam memantau. Jadi mungkin harus ada tarik ulur. Itu yang disebut Prof. Atsushi, kita harus bisa menentukan family center care kita itu modelnya bagaimana. Apakah yang boleh berada di dalam ruangan intensive care itu hanya ayah dan ibu kandung atau pengasuh atau dan lain-lain. Itu terbatas maksudnya. Mungkin itu. Dari saya, dari kami ya, Ikatan Dokter Anak Indonesia memang mencoba membuat satu rekomendasi family center care, tetapi tentu yang ada wisdom lokalnya ya, jadi sesuai dengan kultur kita orang Indonesia ya, biasanya kan ibu yang dekat sama anaknya atau pengasuhnya, tapi tidak mungkin ditunggu terus-terusan, kira-kira seperti itu. Yes, from my point.
Okay, we go to the next question. This is question from Vivi, yeah, our nurse here. He question about how many liter of oxygen we have to give when the patient have SpO2 is 99% in distress syndrome. And what's the other option to use if we don't have a CPAP? Maybe this question for Prof. Akasusi.
Very challenging question. So, not sure if it's a question for high flow. No. Is it a question when patient is on a high flow? If we think so. So, the first of all, what is the saturation target you should have? Saturation target. Do we need to target all the time 99%? Okay, so if imagine if patient cardiac function, heart function, blood pressure, everything's okay. Okay, and simply patient does have pneumonia. What is your target saturation? 98 or above. Okay, 95 to 98. No? Okay. 92 or above. So everyone wants to make it lower? Below 90? Okay. And I guess BB's the target saturation is 99%. But think about it, the good things and bad things of oxygen. Okay, the current practice or current evidence says saturation target with simple pneumonia or ARDS should be lower than we had before. It should be 88 to 92% with good cardiac function. Okay, as long as patient cardiac function is okay, you can aim 88 to 92%. Okay, you don't need to aim 99 or 98%. No, oxygen intoxicity is one of the issue, right? And you need to, oxygen is very costly, very expensive. So you should not oxygen, okay, without any needs. That is, I'm not sure I'm answering the question. And so if patient saturation is 99% with some respiratory distress, keep it. Or maybe you can decrease the FiO2 or liters of oxygen. Okay. And with 100% mask nasal cannula, without high flow nasal cannula machine, you cannot control FiO2 with simple mask, simple nasal cannula. But if you have Airbo 2 or J-Flow or whatever, the high flow machine, you can control the FiO2 with liters. Let's say 20, you can choose 20 liters of FiO2, 0.6, 0.3, 0.4, whatever you like. I think I'm answering the question.
Maybe his question about how many liter to target the FeO2, what do we need without using CPAP or high flow. If is can be used, or we just need CPAP or high flow to maintain the FeO2 with that targeted SpO2, like that.
Your question is
If the
to maintain the saturation,
Yeah.
only to maintain the saturation, how much
maintain
oxygen?
with the FO2 without CPAP or high flow.
Without,
Without.
depends on the condition of the lung, depends on the condition of the disease. Okay, if patient the lung is too bad with pneumonia or ARDS, you may need to give 100%, 10 liters, 15 liters even, and depends on the body weight or tidal volume. Okay, lung condition, body weight, body size is a two indicator. Okay, when we decide the amount of oxygen to provide. Yes.
Okay, I can. Yeah.
Thank you. Maybe I will add about the SF ratio. Yeah, maybe it's not so common. Jadi sebenarnya pertanyaannya sangat bagus sekali, tetapi ini memang harus kita lebih clearkan lagi bahwasanya yang penting tadi sudah ditampaikan oleh Dr. Tomoya dan Prof. Kawaguchi. Itu ada tabel diagram yang dimana apabila setelah angka 98 oksigennya jatuh, lihat kan? Artinya bahwasanya kita tidak perlu sampai 100 selalu, itu maksudnya. Target bahwasanya oksigen saturasi itu kita harus capai, karena pada batas tertentu sebenarnya dia sudah tercukupi. Dan yang paling penting adalah bukan berapa banyak liternya yang kita berikan, tapi berapa banyak oksigen yang dapat diterima oleh tubuh. Nah, intinya kita bisa menilai itu dengan namanya rasio, yaitu SF ratio. Kalau anaknya itu tidak diintubasi. SF ratio itu adalah rasio SpO2, yaitu oksigen saturasi perifer yang kita dapatkan dengan pulse oximetry, dibagi dengan berapa banyak fraksi inspirasi oksigen yang masuk ke dalam atau diterima oleh alveolinya. Di udara ini berapa FeO2-nya? Ibu-ibu, bapak-bapak tahu berapa banyak? Apakah 100% oksigen di dalam udara ini? Tentu tidak, bukan. Hanya 21%. Jadi udara bebas, FeO2-nya cuma 21%. Nah, apabila ada seorang bayi atau anak megap-megap di udara bebas, room air, berarti dia sudah tidak cukup lagi kandungan fraksi inspirasi oksigen yang di dalam udara 21% ini. Itu bukan? Berarti dia butuh oksigen lebih tinggi konsentrasinya. Itulah kita berikan terapi terapi oksigen namanya. Terapi oksigen yang sehari-hari standar kita pakai dengan nasal kanula atau dengan sungkup sepanjang dia masih dengan aliran rendah atau low flow itu tidak stabil. Karena apa? Karena sangat bergantung pada kemampuan dia untuk bernafas. Karena bayi bernafas tidak stabil, itu minute ventilasi namanya, yaitu perkalian antara berapa volume udara yang masuk ke dalam paru-paru atau minute volumenya itu adalah perkalian dari volume tidal, udara yang masuk keluar masuk di dalam alveoli dikali laju napas, RR. Jadi kalau laju napasnya cepat, berarti volume tidalnya mungkin paru-parunya kecil supaya minute ventilasinya tetap. Nah, kalau dengan mesin seperti ini, high flow nasal cannula, oksigen yang diberikan itu tetap nggak akan kurang dia. Nggak peduli pasiennya mau napas mau enggak. Maaf, pasiennya bernafas spontan tetapi tidak stabil. Misalnya laju nafasnya tidak selalu 40 gitu, kadang-kadang 60. Nah, kalau anak atau bayi yang pakai oksigen selang biasa, kalau begitu dia napasnya turun, itu alirannya juga turun karena dia nggak bisa menghirup. Paham ya ibu-ibu ya bapak-bapak? Tapi kalau pakai mesin ini ya atau yang namanya high flow, itu dia nggak peduli napasnya naik turun, itu oksigen yang dihantarkan tetap fix oksigen. Yeah, that's the difference. Yeah, about the oxygenations.
Thank you for the question and the answer. Maybe we go to the next question. If there's any question, from online is the end, is final, is the last question. Maybe from the offline participant, okay? Mike.
Yeah, thank you for the opportunity, Doctor and Professor. First, I apologize beforehand, as I was a bit late earlier, so I just caught a small part of the discussion. I want to ask about HFO. My question is, what is the appropriate time to initiate HFO? Is it a rescue therapy after the failure of conventional ventilation or as a primer of or main therapy for certain condition like, for example, pulmonary interstitial emphysema? Maybe that's my question. Thank you.
Maybe it is for Prof. Akasasi.
Okay. The question is, it's the time to initiate hypernasal cannula on patient with respiratory disease or distress. Okay. It depends on the etiology you want to sort it out. I mean, you want to manage. So if patient, let's say, as I showed, there is a escalation flow from oxygen therapy to high flow, NIV, CPAP to invasive. Okay, so in emergency department or in the pediatric ward, if you find the patient breathing harder, okay, with low saturation, let's say if patient saturation is below 90 or 92 or lower than before, if saturation was okay before 3 hours ago, 97, and now your patient has saturation about 70, 90 or something, you should start oxygen first. No hesitation, oxygen first. How much oxygen? It depends on the patient's saturation. Mask O2, nasal prone, whatever, you should start O2. Okay. And, but again, O2 may not the answer for increased vocal breathing. If patient breathing harder or breathing increased vocal, does have an increased vocal breathing, start high flow anytime, immediately. If you only have CPAP, start CPAP. No hesitation. Okay. And again, initiating high flow is very easy, but evaluation of the high flow effect is very difficult to do. Okay. Every time after you start high flow, try to evaluate the patient every 1 hour, every 30 minutes. Okay. And if there is no sign of improvement, escalate. So the support to CPAP, BiPAP, and invasive. Okay. The only message for you is not to leave the patient alone with high flow. Okay. Someone may be, satisfied with high flow. Saturation for sure. That saturation SpO2 should increase with high flow if you give higher amount of FiO2, for sure. But again, saturation, SF ratio is not the answer. It's not the only answer to think when we think about the increased vocal breathing or effect of high flow. Okay. And so the one of the tricky part is the cost. Currently, the machine is not available anywhere. So, and also the cost, you may think about the cost when you start high flow. But again, high flow may decrease the intubation rate eventually. Right? So, as I said, 70–80% of the patient children with respiratory disease does not need intubation with high flow practice. So that can change your practice or healthcare cost a lot. That's most of the country observed over the last 10 years. So cost, you need to think about the cost, but the message is please do not hesitate to start using high flow if you can use it. Okay.
Okay, maybe what about the questions? Okay. Okay. Yeah. Okay, we start next to the last question because it's 12 o'clock. We have to get a lunch. Yeah. From offline, online, there is any question? Oh, okay, Dr. Watia. Dr. Tia. Mike, please.
Thank you. Maybe my question is for Professor Ashishi. I want to ask how long we need to evaluate the progress of the patient after we use the device. Example, this device for a patient according to decide whether the patient needs to revert to another facility with advanced apa namanya fasilitas gitu. How long we need to evaluate minutes or hours. We don't want the patient is doesn't have tidak mendapatkan penanganan yang cepat gitu.
Effect of high flow. Yeah. So less than longer than 2 hours. So I discussed a lot with my friend in the UK, the author of the first ABC study, the first ABC study I showed, the RCT, biggest RCTs ever been published. And so bottom line is, after starting high flow, at least if patient does not have sign of improvement within the 2 hours, think about the escalation, okay, to CPAP or NIV or intubation. Okay, 2 hours, 1 to 2 hours is the answer. To time, but it depends on the patient condition. Patient is struggling a lot, breathing faster even after high flow initiated. You should not wait 2 hours. But if saturation is okay, his consciousness level is okay, and the heart rate is not escalating, you can wait till 2 hours, maybe 1 to 2 hours. High flow nasal cannula, yes, make the saturation number better for sure, immediately. But the breathing pattern, it takes maybe 1 hour, 2 hours to start showing the effect of high flow nasal cannula outside of the oxygenation. You know what I mean? So because the biggest goal, why we want to have higher saturation? What do you think? Is why we want to give a higher saturation instead of lower saturation? Because we want to deliver the oxygen to the tissue, body tissue. No? The goal is, our practice is to provide the oxygen to the tissue, body, right? So it takes a while to start showing the effect of respiratory support. Maybe you can.
Okay. Maybe I can add some more because your explanation is wide enough. Jadi pada intinya, apabila seorang bayi dan anak mengalami gejala gawat napas, gagal napas, dan kita bisa lihat apa tadi secara klinis, oksigennya turun, apabila kita bisa menilai dengan pulse oximetry. Kemudian yang paling penting secara klinis apa? Adanya peningkatan upaya bernafas. Walaupun katakan saturasi bisa 99, ya enggak, tetapi dia sudah megap-megap. Atau walaupun misalnya sudah diberikan terapi oksigen dengan oksigen standar, itu tadi yang kita katakan namanya low flow. Yang sehari-hari kita pakai itu low flow, aliran rendah. Walaupun dokter-dokter, ibu-ibu, bapak-bapak kasih 10 liter, ya kan? Itu alirannya 10 liter, tapi kan itu di dalam apa? Di dalam oksimetriknya. Tapi apakah itu masuk ke dalam tubuh pasien? Nah, itu yang disebut Prof. Asusi tadi. Yang penting kita targetnya adalah menghantarkan oksigen yang dapat dipergunakan oleh tubuh. Nah, walaupun kita kasih sampai 10 liter, tapi tubuh nggak bisa ngangkat. Karena terjadi proses gas exchange itu, pertukaran gas itu di alveoli. Jadi harus ada satu lagi parameter, yaitu apa? Aliran darahnya cukup baik. Ya, nah itu jadi VQ namanya ya. Jadi apa yang diberikan, oksigen yang kita hantarkan diikat oleh tubuh dengan hemoglobin pastinya, dan kemudian dibawa dengan aliran darah sampai ke jaringan. Itulah target yang disebut Prof. Atsushi tadi. Oksigen yang kita hantar itu harus sampai kemana? Ke tisu. Tisu itu jaringan tubuh. Ya, itu targetnya, terutama pasti sel. Oksigen itu perlunya di dalam sel sehingga masih tetap terjadi metabolisme. Sehingga parameter-parameter yang ada saat ini dipakai adalah pertama pastinya kita kembali ke klinis. Apakah anaknya masih tetap megap-megap dikasih oksigen? Kita bisa nilai mulai escalating. Escalating itu namanya berjenjang. Dari mulai oksigen pakai binasal itu yang di hidung itu hanya maksimum bisa 2 apa 3 liter. Lebih dari itu akan menyebabkan laserasi atau hidungnya berdarah, lecet, nggak boleh. Kita eskalasi kemana? Ke modality yang lebih tinggi lagi, yaitu sungkup, simple mass. Simple mass itu kita bisa berikan sampai 3 sampai 4 liter, ya kan? Kalau simple mass atau 5 liter bisa. Itu bisa menghantarkan fraksi inspirasi oksigen sebanyak-banyaknya cuman 40%, 45%. Nah, kalau masih megap-megap juga dengan simple mass, artinya anak ini butuh lebih tinggi lagi. Paham ya? Kalau pakai binasal kanul kan paling-paling 30%. Kita tingkatkan lagi pakai apa? Rebreathing mask, RM. Rebreathing mask bisa menghantarkan oksigen deliverynya itu lebih kurang 60%, 60% FiO2. Kalau anaknya masih megap-megap, ya artinya mungkin dia bukan hanya problem fraksi inspirasi oksigen, dia butuh flow, dia butuh aliran yang lebih cepat ya seperti high flow nasal kanul atau kalau kita punya CPAP kita bisa berikan. Tapi itu bukan selalu jawaban. Karena belum tentu dia juga butuh PEP. Kita tahu PEP yang di CPAP itu adalah untuk memberikan tekanan apabila alveolinya kempes di tangga lagi. Itulah guna PEP. Tapi kalau alveolinya enggak kolaps, itu juga anfaedah. Gitu kira-kira. Jadi banyak hal yang dipertimbangkan sehingga pemberian high flow nasal cannula itu masih cukup make sense apabila kita punya karena dia hanya memberikan aliran dan memberikan oksigen. Jadi tidak memberikan PEP. Kalaupun ada dia berikan ada sedikit PEP untuk tidak sampai paru-parunya menjadi atau alveolnya kolaps. Apabila tidak juga jangan ragu-ragu untuk segera intubasi. Itulah. Jadi itu eskalasinya. Yang paling akhir adalah intubasi intervensi dengan mechanical ventilator. Mungkin itu.
Okay, because of limited time, we have heard from three amazing speakers today who have given us different perspective and insight on comprehensive pediatric critical care. Yeah, the first speaker from Dr. Tomoya, the second from Dr. Riri and Prof. Akatsushi. So let's have final round of applause for the three of our speakers today. Yeah. Thank you for your attention and participation. I give it back to MC. Thank you.
Thank you to all the speakers for the outstanding knowledge. And thank you, Dr. Zubaida Hayanusa, Specialist Anak, for being our moderator on this event. To show our appreciation for the time you took to come to Ambon to visit us, please allow us to present you with a souvenir as our regard. To Dr. Fuji, you may join the others. Please stand up. First souvenir will be presented by Dr. Fahmi Marwa Pei, Specialist Anesthesi, as our Medical and Nursing Director. Please, Doctor. All of you may stand up. Dr. Fuji, please join the others. This is a plaque from RSUP Dr. Johannes Lemena Ambon to all the speakers, Prof. Atsushi, Dr. Tomoya, and Dr. Riri. The second souvenir will be given by Dr. Fahmi as well. Dr. Fahmi, please stay for a while, then we take a picture. So please stay. The last gift is from the Indonesian Pediatric Society, Molucus branch, will be given by Dr. Zubaida Hehanusa, spesialis anak, and Dr. Mutia. Please join in front. Yeah, we're gonna take a picture first. Thank you, Dr.
Saya
Tia.
tunggu sebentar. Semua peserta jangan dulu pulang. And Dokter Asasisi Prof Asasisi mau memperkenalkan penggunaan HFO, ya. Nah, jadi nanti tolong mendekat. Nanti kami translate ya.
So we can take a picture.
Tadi lupa ya. Jadi tolong ya apa nama kamera di apa namanya?
So we're gonna take a picture with all the attendings. Teman-teman semua, kita akan foto bersama dengan Prof dan juga para dokter sekalian. Setelah itu jangan pulang dulu karena akan ada workshop untuk penggunaan high flow nasal cannula. Jadi sekarang langsung diperagain.
Tunggu kita praktek dulu ya.
Praktek
Kita
dulu
praktek
penggunaan
dulu. Ya. Terutama yang teman-teman dokter umum sama perawat maju. Ya. Cara merakit ya, terutama cara merakit supaya nanti ini alatnya ini tolong di rumah sakitnya dicari ya. Nah, tolong ini alat ya, ini alat ini sudah diberikan oleh Kementerian Kesehatan ya kepada kita semuanya di rumah sakit pada saat COVID. Jadi tolong dicari ya, tolong dicari di gudang. Siapa tahu ada ya.
Ya, teman-teman boleh
Ini
merapat dulu.
oksigen.
Boleh merapat terlebih dahulu. Boleh mendekat, teman-teman.
Tolong lingkarannya melebar supaya semua kelihatan ya. Jangan sambil kalau maju itu nanti susah. Ya,
Boleh
jangan
ambil
terlalu.
video.
People in a very close, just in this now.
Boleh duduk di bawah dulu kayaknya deh. Duduk dulu di bawah. Ya, kayak dikasih kuliah ya.
So this is the machine is called Airbo 2. Okay, Airbo 2. It's not portable. It's not portable. You can use this only inside of the hospital. Okay? And very simple, very simple. The first thing is to AC plug in first. Okay? And then this is called chamber, okay, to humidify and heat the air. Translate.
Jadi ini chamber atau tempat untuk jadi humidifier. Nanti itu diisi sama air. You may continue. Buka ini dulu. Jadi ada dua bagian. Nanti disatukan bagian yang satu dengan bagian yang lain. Jadi bagian itu akan, bagian bowl-nya ini akan harus masuk di dalam situ.
Push here.
Jadi biar mudah, nanti bagian bawahnya ditekan dulu, baru dikasih masuk ke dalam. Ya, sampai bunyi klik, baru.
Done. And okay, this is the sterile water. Sterile water. Okay. If you don't have this kind of things, you can pour. No, before placing, you can pour some water. You should not use normal saline, just the sterile water. Okay, sterile water.
Jadi ini pakai air steril, steril water. Jangan pakai normal salin dalam bowl ini. Kalau misalnya nggak punya ini, berarti boleh pakai air yang lain, tapi jangan tap water, jangan air biasa. Soalnya air biasa kita beda sama punya mereka.
Okay, and then connect here.
Kalau ada yang kayak gini boleh pakai.
Comes in.
Nanti airnya
To
bakal turun ke
chamber.
dalam bowl-nya, dalam chamber-nya.
Okay. And okay. And also you have this, it's the circuit to the patient. Okay.
Jadi ini yang panjang nih akan dihubungkan dari alat ke penggunaan ke pasien.
Okay. This comes to here.
Jadi ini ada buletan di tengah sama ujungnya dua, nanti dicantol ke sini, ditekan ke situ.
Okay. And now you should turn on the power. Okay. Press here.
Nanti ada tombol power di bagian atasnya, boleh di-press, ditekan untuk kasih nyala alatnya.
2-3 seconds.
Selama 3 detik. 2 sampai 3 detik.
But water is coming.
Iya. Minta.
So it takes a while to start. It takes almost 1 minute.
Akan ambil waktu 1 menit untuk dia betul-betul nyala. Untuk alat ini betul-betul menyala. Duduk di bawah teman-teman. Boleh duduk di bawah biar yang beliau bisa jelaskan bisa kelihatan semua. Boleh duduk di bawah dulu.
So you don't have oxygen? And if you have oxygen, we don't have oxygen right now, but if you have oxygen, use this connector here to the patient. This is to the tank. Okay, tank.
Jadi
Okay.
kalau misalkan ada oksigen, ini yang biasa buat nasal kanul, tahu kan? Nah, ini nanti di connect-nya ke sini satu, sama ke tempat oksigennya satu.
Okay, so it's heating up now. Can you see here? It's indicating 9, 20, 29, 20, 21% right now, but it's still thinking. It's thinking. It's still thinking. So once it's done, it can tells us that we can manipulate and change the setting. Okay, it's still thinking like Google.
Jadi ini sementara masih loading. Jadi di sini sudah nampak ada kehangatannya, derajatnya, sementara dipanasin alatnya. Terus habis itu di sini juga ada berapa liter per menit, sama ada oksigennya udah berapa persen. Nanti setelah dia sudah loadingnya selesai, ini akan bisa disetting sama kita sendiri.
Okay, and I think you have this is the adult size. It can be used for maybe 10 kilo or 20 kilo infant. Okay, you can hear this.
Tadi bisa dengar suratnya.
Sound, right?
Nah, itu berarti sudah selesai loading.
So when you open this, you can find this. Okay, but keep in mind, this size is very important. Okay, near size should not, so this should not occlude more than 50% of the nail. Okay, so if your baby's nail hole is very small, you should not use this. Okay, it depends on the patient.
Jadi ini buat dewasa sebenarnya. Tapi kalau misalkan mau pakai untuk anak dan bayi, harus menyesuaikan dengan bentuk hidung. Tidak boleh lebih dari 50% besarnya. Jadi harus menyesuaikan. Jadi kalau kayak ini berarti anak nggak bisa pakai.
Why? The reason because is that if you occlude entire nair and a patient close his mouth or her mouth, that can cause the bowel trauma. Okay, place too much pressure. The air cannot escape anywhere. Right?
Jadi kalau misalkan kita pakai yang besar dan menutupi seluruh hidung, itu akan menyebabkan barotrauma. Jadi kalau barotrauma itu udaranya itu akan tidak tahu mau lari kemana, apalagi kalau pasiennya dalam kondisi menutup mulut, ya.
Okay. Now connect this to here. Okay, easy. And then, okay, change the set. Okay, when you choose a setting, press 2 button at the same time. Press more at 2-3 seconds. Okay.
Jadi pada saat sudah connect konektornya ke yang lain,
before that you should so from this which one you should change, you should manipulate. If you want to increase the temperature of the humidifier, choose this, press this, and then it's locked. So place both of the button at the same time for 2 seconds.
Jadi di sini ada tiga yang bisa disetting. Yang pertama suhu.
Yeah, it's now unlocked and you can change the temperature 31, 34, 37. Okay. And the temperature you should choose, it depends on the temperature of the room. Okay. Okay. If your room temperature is very low with high temperature of fire, the circuit will be moistured too much. Too much. So 34 is the safety length. Maybe you should choose 34. Begin with the 34. Okay. Next, liters. What is the tentative guide of the flow? So 10 kilo children start with
Jadi anak 10 kilo biasanya berapa flow-nya?
2 times 2 liters per kilo, right?
2 liter per kilogram.
So if you have 20 kilo children, you should start from 40.
Jadi
Okay.
karena anak 20 kilo berarti 20 dikali 2 karena 2 liter per kilogram
Again,
berat badan.
press the button, 2 buttons at the same time, and unlock, and you can increase to 40, and then done. Lock.
Ya, jadi di sini sistemnya lock unlock. Jadi kunci dan dibuka. Bisa dengar?
Yeah. Okay. And if you have, then we don't box, so we cannot change the FiO2. If you have oxygen tank, you change the. Okay, theoretically, if you are given 40 liters of air so if you can provide 100% of oxygen from outside of this device, from tank, 40 liter per minute, theoretically you can give 100% of FiO2.
Jadi kalau misalkan ada oksigen tabung, biasanya kalau misalkan di sini disambungin ke oksigen, dia akan berubah. Kita bisa atur. Kita bisa atur. Nah, logikanya kalau misalkan dia pakai 100% udara luar dan 40 dari sini, berarti hitungannya 100% udara luar ini.
Yeah, that's all. That's all. And so someone will try this.
Ada yang mau coba? Pakai ini? Ya. Ada yang mau coba enggak? Ya. Oh. Oh, you wanna try? Ya. Ya.
Okay, so now
Ya, press the yes.
okay. Okay, you can wear.
Ini mau di trial ya, mau dicoba dipakein ke pasien. Contohnya jadi pasien ya. Ini dikasihnya cuma 10 liter per menit. Oke. Ini bisa kepake karena dia dewasa.
So now it's 10 liters per minute. You feel nothing, right? Warm.
Cuma kerasa hangat aja, nggak rasa apa.
Okay. And I'm gonna increase the flow. E.
Ya, you gotta feel something. See, kalau hitung 40, udah dinaikin tadi dari 20, dia sudah mulai merasa ada anginnya. Sekarang udah naik 40 liter per menit karena dia ngerasa warm, ngerasa hangat di hidung dan agak sulit bernafas ya. Agak susah buat nafas soalnya oksigennya.
Opening them. And you want see? No. And what you can make.
Kalau dinaikin suhunya, dia akan ngerasa jauh lebih hangat. Jadi semakin suhunya naik, humidifiernya akan nyesuaiin biar gimana pasiennya bisa ngerasa lebih hangat. Tapi safe-nya main di 34 derajat aja dulu. 20 is fine. Yeah, 20 is fine.
But you feel some peep, right, with 40. Okay. So one. Okay.
Okay. Okay. Okay.
Okay.
Thank you very much. Okay. So if they want to clean this, they cannot use alcohol wipes, right? So no alcohol wipes. Nggak boleh pakai kas alkohol, karena itu bakal ngerusak karetnya. Gitu. Ini tuh disposable sebenarnya.
Yeah.
Jadi
This is disposable.
Yeah.
So theoretically, or from the company, what the thing is, this should not be used for multiple patients. However, right now, you don't have many parts right now. So if you want for multiple times, you need to clean it up and dry it every time. Okay. So when you clean it up, want to clean it up first. Okay. First, turn off. Okay. Disconnect. Okay. And disconnect here. Right. So, but here, you should seal here and a washout inside, only inside. Washout only inside. Okay. And you can use maybe still water. Okay. I'm not sure you can use the tap water. No, maybe just the this water, still water, flush it. Maybe you can use the 50cc syringe or something and flush it. And then try to dry it up.
Jadi karena kita nggak punya banyak, pasti ini harus biasanya sih dipakai buat beberapa pasien. Tapi sebenarnya ini sistemnya disposable, jadi nggak boleh dipakai ulang. Sekali pakai buang, sekali pakai buat satu pasien aja gitu. Nah, tapi kalau kita nggak punya, jadi ini cara membersihkannya adalah di unconnect dulu, dilepas semuanya, terus di flush pakai sterile water. Dicucinya dimasukin dalam sini. Sterile waternya dimasukin dalam situ baru dibiarkan kering. Jangan dikeringkan pakai apa-apa, dibiarin aja kering.
Again, what I said is not the way of recommended things.
Jadi ini sebenarnya bukan cara yang direkomendasikan.
Okay. Okay. Ideally, you should change every time when you change the patient. Okay. Okay. And the size-wise, this is the adult small size. The smallest size you have in Indonesia, I believe.
Yeah.
Okay. In Chipto, they have some multiple child sizes. However, there's nothing in other hospital. So, smallest size, I believe, the body weight would be, I don't know, maybe 7 or 8 kilo. Yeah, given the size of the here. Okay.
Oke, jadi karena ini punya yang adult kecil, seharusnya kalau buat pasien pediatrik kan pakainya yang kecil ya, yang infant atau yang pediatrik punya yang kecil. Tapi kan kita nggak punya, jadi menyesuaikan saja.
The other tips would be, so whenever you finish using this, you need to disconnect this chamber as well and wash it up and dry it up. Okay.
Jadi bukan hanya ini yang dicuci, ini juga dikasih keluar. Caranya adalah ditekan lagi bagian bawah yang ini, terus dikeluarin. Tapi hati-hati karena panas. Karena kan tadi diangetin kan, pakai suhu yang diatur, jadinya dia panas.
It's very hot right now, so leave it for a while. Okay. And the other things is, please do not put any single medication into here. Even if you want to use like Benetolin or epinephrine, please do not insert or inject the medication into the chamber. Chamber is very fragile, very easy to be broken. Okay. So and particularly the epinephrine, the pH level is very low, very acidotic. No, so please do not use that way. In that way.
Jadi di chamber ini tidak boleh dikasih obat-obat apapun. Dia hanya boleh ada sterile water aja. Nggak boleh ada obat epinephrine, Ventolin apa, katanya kayak Monebu nggak boleh. Jadi cuma boleh ada sterile water saja karena chambernya sangat cepat rusak. Kalau misalkan ditaruh apa-apa, apalagi kalau contohnya epinephrine itu pH-nya di bawah, sangat asidosis. Jadi kalau misalkan ditaruh akan rusak. Yeah. Anything else you wanna teach him?
Any questions?
Any questions so far? Ada pertanyaan? Bahasa Indonesia boleh, ntar aku translate.
So I would suggest you to make a checkup wrist, check wrist or something before start using this. Because if you don't have still water inside of the chamber, it's gonna be a disaster. Dry air, can you imagine? Dry air, 40 liters, dry air is coming in. It's gonna be a disaster. The patient will be having nosebleed for sure.
Jadi jangan lupa ini diisi air, karena kalau misalnya diisi cuman udara aja, kalau kalian kasih pasang ke pasiennya, itu pasiennya bisa, itu bencana sebenarnya. Jadi pasiennya bisa hidungnya berdarah, ya, bisa iritasi, kayak gitu. Ada pertanyaan? Any question from you guys? Kalau ada yang bahasa Indonesia boleh, ntar aku bantu translate. Sudah paham semuanya?
Anyone has this device in your hospital?
Ada yang punya alat yang sama di rumah sakit? Yang lain? Ini punyanya. Selain rumah sakit Tulehu, apakah ada yang punya?
And one other thing is, again, this is not for transport. Okay. Even if you have AC adapter inside of the ambulance, you may be able to use it, but the Fisher Paykel, the company is saying it's not to be used for transport because it's not safe. The chamber needs to be on the flat floor, flat here, right? So if this in the bumpy road, maybe the hot water is going into the patient side. Okay. So it's not allowed to use it for transport. But if you don't have anything, and if you really, if you can be very, very careful and then hold it during the transport, you may be able to use it for transport. Yes.
Ya, dari company-nya sebenarnya tidak pakai ini untuk transport. Jadi pakai di mobil atau pakai buat rujukan tuh ini tidak disarankan. Memang bukan dibuat untuk dipakai transport kemana-mana. Karena dia harus di tempat yang rata. Supaya ininya gak gerak-gerak. Karena kalau misalnya gerak, satu, yang pertama ini panas. Kalau airnya tumpah bisa kena ke pasien. Yang kedua, kalau misalkan dia airnya goyang-goyang, udara luar bisa masuk. Akhirnya nggak pure sterile water. Paham ya? Nah, jadi ini nggak boleh dibawa tapi misalkan contohnya ya udah deh nggak ada lagi, cuma ada ini mau dipakai transport, boleh, tapi yang penting pegang, yang penting jangan goyang-goyang karena kan jalan kan bumpy ya, maksudnya gerak-gerak apa segala macam. Tapi kalau bisa mempertahankan posisi ya sebenarnya boleh saja, kan keterbatasan ya, tapi tidak disarankan untuk pakai transport. Ya. Okay? Everyone understand? Any question? No? Oh, so they really understand what you're saying. Okay. Thank you, Professor Atsushi.